Good evening, everyone, and thank you for joining us tonight in Denver. We hope you had a successful energy meeting so far. I'm Dr. Tom Herzog, and I'm joined tonight by my co-MC, Dr. Bradley Monk. Brad, say hi.
Thank you, and welcome. Thank you for being with us tonight.
We're very excited to welcome you to GOG's 10th highlight reel. Tonight, we will be sharing content from the meetings that took place over the last 6 months, and it's our goal to provide important context for the latest advancements in GYN oncology. A warm welcome to our outstanding faculty, Dr. Coleman, Dr. Moore, Dr. Iskander, Dr. O'Malley, Dr. Pathori, Dr. Randall, Dr. Slomovitz. Special thank you to Dr. Pathori and Dr. Iskander for thoughtfully and thoroughly putting together such a great program tonight. We really appreciate it. Yep. We also want to welcome our invited speakers, Dr. Rachel Grisham and Dr. Joyce Barland. Yay. Yay. All right, I'd like to begin by sharing our foundation's mission and vision. The GOG Foundation is committed to developing and providing access to the latest clinical insights so that together we can improve outcomes and make a meaningful difference in the lives of our patients. Our recently updated mission reflects the important work that we're doing to advance education and support progress in GYN oncology. As scientific discoveries accelerate and new therapies become available, the need for trusted, timely education continues to grow. Brad, I'm going to turn it over to you to get us started.
All right, ready to rumble? Let's go. As Tom said, this is number 10. Tonight we will share key data, trials, concepts, and help all of us better understand the treatment opportunities. We are really interested in your feedback. We've made a few changes here. I think this is going to be very fun to do audience response. So what I'd like you to do, it's also at your tables, to scan this QR code, ultimately to take the pre-test first. And then ultimately this helps us keep this content fresh, engaging, and innovative to you. So this is very important. Again, I think it's going to be very interesting to see what your colleagues do. We were very excited. We hope you enjoy the hard work that Jenna and her team has put forward here, Lindsay Muller, and the list goes on and on. See our agenda here. We will be presenting hypothetical cases, although they may seem like the cases that you see regularly in your clinic, to understand how to utilize the new and approved agents, but also the changing clinical landscape as we enroll to our clinical trials. So the overall objective to this session is to showcase clinical trials and other newsworthy education from the major meetings that have happened in the last 6 months, predominantly, but not exclusively, the Society of Gynecologic Oncology, American Society of Clinical Oncology, and ESMO GYN. Additional learning objectives are listed here on the slide, as well as the agendas on your tables. Our expert panelists will engage through dynamic discussions, and we also, as I said, invite you to think of questions. We have handheld mics, and we will have question and answer sessions. Go ahead, Tom.
Yeah, GOG Foundation's proud to be an ACCME accredited provider. GOG goes through a rigorous process to review, edit, delete, and update any content that may not follow ACCME guidelines. This program is accredited for up to 2.5 hours for CME credits. For those of you wanting to claim CME for this course, you'll need to complete the post-meeting survey, which we will email after tonight's session. In accordance with ACCME accreditation criteria, the GOG Foundation, Inc., as the accredited provider of this activity, must ensure that anyone in a position to control the content of the educational activity has disclosed all the relevant financial relationships with any commercial interest. Designated officials review the content presented and manage all reported conflicts to ensure a bias-free presentation. And faculty disclosures are detailed on this slide as well as on the next slide, or on the last slide there. All right. Note that some of the presentations and discussions today may include off-label use of products and/or devices. All content shared tonight includes permissions and details that are in the public domain. Brad?
Yes, thank you. So we could not do this without our supporters. And there's not a day that goes by that we don't use medicines that these sponsors produce. So we're very grateful to you for not only supporting this educational opportunity, but also for bringing medicines to the clinic, again, that impact patients' lives. Importantly, this is independent medical education. There was no external influence in any of our presentations by these supporters, and I want to name them by name: AbbVie, Acrivon, AstraZeneca, Corcept Therapeutics, Eisai, Eli Lilly, Gilead, GSK, Karyopharm Therapeutics, Merck, Pfizer, and Veristem. Thank you. Guys, we're going to have to get a little bit more fired up than that. That was a little anemic, but that's okay. We appreciate those that clap. So I already said we're ready to rumble. Like we mentioned in the opening comments, we're going to make this very interactive. Again, we invite you to participate as an audience. Please scan the QR code again to participate. And if you have a question, please come to one of the microphones that we'll distribute. So finally, to stay on schedule, Dr. Herzog and I have a hook. I'm sorry. We will be enforcing the time limitations for the presentations. So we're going to kick it off here. We're going to start with ovarian cancer. We have modules in all three tumor types. We're very honored to have Professors Iskander, O'Malley, and Grisham from San Diego, Columbus, Ohio, and New York, New York. Dave Ramez, we're going to turn it over to you. Thank you for being with us tonight.
Thank you. Thank you for the kind introduction. It's an exciting time. We are thrilled to be here to talk about the ovarian cancer treatment landscape and opportunities, and really to engage in this highlight reel. We're going to start with a case today. This is a 70-year-old patient who presented with abdominal bloating, pain, constipation, typical symptoms with an advanced stage ovarian cancer. CT imaging showed an 8-centimeter pelvic mass with concurrent ascites and suggestion of peritoneal carcinomatosis. She was able to undergo a primary cytoreductive surgery with a complete gross resection. Final pathology confirmed a stage 3C high-grade serous fallopian tube carcinoma. Germline testing was negative for pathogenic mutation, and as I hope we are all performing, in addition to germline testing, additional genomic or next generation testing showed HRD test negativity, HER2 0+ by IHC, PD-L1 CPS score of 1, and FR alpha expression of 65% 2+. I wanted to take a moment once again to remind our group of the robust frontline clinical trial portfolio that we have available. Just briefly, NRG-GY036 is restricted to HRD test positive or BRCA mutated patient cohorts. We talked about this earlier today in the ovarian cancer session. And interestingly, the remainder of the trials that you see up here actually exclude that patient population. So it's a great opportunity for all of our sites to engage in having multiple frontline studies available to facilitate enrollment and move the science forward. And I just want to also take a moment to say that it doesn't stop here. There are multiple other trials in development. These are the ones in the public domain. And I highlight in the schema on the bottom right that there is overlap to some degree in the design of these trials, as they are maintenance designs with novel ADC plus or minus Bev versus standard of care, which could be Bev versus observation strategy. So please, if you don't have a study open at your institution, I reiterate, reach out to us because we are eager to have you participate in the conduct of these trials. So NRG-GY036 was the only frontline study open at the institution. The patient was treated with carboplatin, paclitaxel, and bevacizumab, followed by bevacizumab maintenance, as they were HRD test negative, as I alluded to. Had 6 cycles of adjuvant chemotherapy with maintenance bevacizumab. After 24 months from completion of cytotoxic chemotherapy, imaging was suggestive of disease recurrence in the context of right upper quadrant pain. IR image-guided biopsy confirmed recurrent high-grade serous fallopian tube carcinoma with intraparenchymal liver metastases, as well as alternate sites of disease suspicion. And this is platinum-sensitive disease, certainly in the context of the treatment-free interval. Pass it back to Dr. Herzog.
Yeah, so we have a platinum-sensitive patient here. She's 24 months out. Leslie, what's your treatment of choice in this clinical setting? So you have PSOC patient, she's HRD test negative.
Mm-hmm. Well, platinum doublet, and gosh, I mean, I would go straight to clinical trial, hopefully in this setting, and I think you're going to show us several options here coming up. but platinum doublet, and then Bev, even if they'd had Bev before, I'd go with Bev here.
Katie?
I would be looking, so she would likely meet, you didn't talk about whether or not she had ascites, she'd likely meet AGO over desktop criteria for consideration of secondary cytoreductive surgery. So I would be thinking about that very strongly in this patient, followed by platinum, PLD, Bev maintenance, and then clinical trial.
Okay. Bhavna?
Yeah, I agree with that. I would assess for
Rob?
cytoreduction.
And I'd resequence her too. I'd resequence at this point, 2 years
What are you
later.
looking for on the resequencing?
I would be really looking for less so the mutations because we don't see a lot of drift, but I'd be looking for folate because she was folate medium. I'd be looking for folate. I'd be looking for
65%.
HER2, right? And I'd be looking increasingly for cyclin E overexpression for clinical trials.
Yeah. I know a lot of people in the audience probably still think about surgery in this case, and I think it's still a good option for patients. The most important thing I do actually. But the most important thing that I think that people need to understand is that that there's harm for not being able to do complete gross resection. So evaluation of this patient who has liver mets would be kind of key to determine whether or not you felt this patient was actually completely cytoreductive. If you leave disease behind, every one of the trials, SOC1, Desktop 3, and GOG 213 all show detriment if you don't do a complete resection. So you need to be fastidious in making that assessment evaluation.
And what that does, that really excludes the HIPEC even conversation, frankly. So I thought that was good.
Yeah.
Well, I'm sad that HIPEC was left out of the first case, but it was a primary. It was primary.
It was
So it wasn't adjuvant, so
Yes.
there's redeeming quality. I think
All right.
Back to
Back to this P stock that we're on right now. Let's get back to this. So, do you commonly reuse bevacizumab? Anybody?
Oh, yeah.
I do,
Always.
absolutely.
Who doesn't?
Definitely.
Europe.
Europe.
Yeah, see, if there's a
Canada.
Certain parts of Europe, actually.
restriction on use, yeah, but otherwise from our data wouldn't be harmful.
Yep.
Particularly in this treatment-free interval of 24 months, you've stopped the primary Bev. I don't know if you said it, but at 12 months. So I think in
been
this
off.
instance, I would absolutely bring it back.
Yes.
Yeah.
Until we have something better.
All right. How many would we didn't get a lot of details in terms of what lobe of the liver it was and things like that,
Right.
but how resectable this is, and to Rob's point, absolutely spot on. We don't want to do harm. How many people would, let's say it looks resectable, would do secondary cytoreduction?
I mean, I would
With
absolutely-
isolated disease?
Yeah.
Yeah.
Oh,
But I think the point Rob made, reiterating that the very thoughtful approach, diagnostic laparoscopy,
Yep.
potentially at the start before committing because of the implications.
Okay. So we have a lot of ADCs in this space, and we'll let you take it from there. But it would be a great clinical trial opportunity.
Undoubtedly.
We can convey that teaching point.
You got it. So yes, setting us up
Well, there it
beautifully. So once again, we have a robust platinum-sensitive clinical trial pipeline. And I do want to highlight the fact that, yes, there are antibody drug conjugate-based clinical trials that are looking to explore opportunities for us to improve outcomes in patients with platinum-sensitive disease recurrence. But I also want to take a moment to highlight the fact that as you consider clinical trials in this treatment landscape, there are both opportunities for us to replace potentially certain cytotoxic chemotherapy drugs with ADC. We will call those treatment opportunities. And there are clinical trials that are designed to allow for cytotoxic chemotherapy doublets followed by maintenance ADC strategies. So once again, they're not universally overlapping in the design. There are some shared components, but it also is an opportunity for us to have several studies available at our institutions to meet the needs, of course, of the patients that we're looking to improve clinical outcomes for. So I just want to take a moment here. This patient was enrolled and treated on a platinum-sensitive clinical trial, and I intentionally, in this hypothetical case, will mention that they were randomized to the control arm because we have to remember that our patient populations will be treated with standard of care if they're randomized to the control arm, and that gives us opportunities for subsequent lines of therapy on trial once again, if it's relevant and appropriate for that patient. Treated with carboplatin, pegylated liposomal doxorubicin, and bevacizumab, followed by Bev maintenance. It was not biased by the panel, it agreed, thankfully. 3 months onto maintenance therapy, did develop proteinuria that was evident on urinalysis with a 24-hour urine total protein showing over 2,500 milligrams. Bevacizumab was held, And interval imaging, and I'll transition here on to Dave moving forward, shows disease progression 4 months after completion of combination platinum-based therapy.
So, when we look here, it's not going, wait, sorry. It's important for us to think about the options here on the BEV, right? And we have the interval imaging showing the disease progression. Should we brought the BEV back up, after we did a full assessment? We partner with our nephrology colleagues a lot here.
There you go.
Unfortunately, with now secondary platinum resistant, right? So Tom,
Yeah.
take over.
Yeah. So what's your standard of care treatment of choice in this clinical setting? So what are you going to do? What are you thinking about doing?
Clinical trial.
Clinical trial.
Top three. Number
Right.
four.
So, why is standard of care?
Available therapy.
Yeah, what's
Yeah.
number four?
Yeah.
Yes.
So from that standpoint, I think looking at the folate receptor alpha at 65%, NCCN compendium listing, I would consider MIRV-BEV here.
Yeah.
0 from we didn't put it back up here, but 0 on HER2, so that's off the table.
Right.
Looking at the new data with regards to weekly taxanes, previously I've held weekly taxanes until I needed a win, right? Later on. But with overall survival benefit, I think we really need to think about the weekly taxane combination regimens at this point.
Agreed.
Rob, I've heard you talk about CysGem here, though.
I do like that.
I know you do. That's why I'm calling on you, my friend. Is that this patient is not refractory to platinum. She's resistant. It's been 4 months. It's hard to imagine that a CysGem regimen would not be very active. Tell us how you would make that decision, because platinum-resistant recurrent ovarian cancer is sort of a misnomer. That's a regulatory term.
Yeah.
Now the question is she eligible for retreatment to platinum? And the clinical trials that you guys are going to talk about doesn't have platinum in the control arm.
That's right.
So tell us.
How many were at the session that we spoke about this on? Nobody?
Symposium.
Yeah, the symposium. Yeah, so this was, I'm glad you brought it up, because we had a chance to talk about, what
That was yesterday. That was a long time ago.
Okay, yeah. I guess I gave you guys too much credit. So I think it's good. And you're right, I do. Outside of these trials, now we don't have the long-term data for OS that we have in the trials that you just mentioned, and certainly we have to acknowledge that. But I have used a lot of biweekly. I use the biweekly CysGem combo where both drugs are given because of the drug-drug synergy, and I like it. I do, and I use it.
Okay. And the one thing you say she's not refractory, she might be refractory.
We don't know. Yeah.
By the time she's got a liver lesion that you could easily see, 4 months. I mean,
I just think
she wasn't
it's on the
responding
table.
well on
It's
platinum.
on the table.
Yeah.
It's on the table.
Particularly if you resected her.
It's not when I usually
There
use
you go.
Yeah, if
There
you
we go.
resected her and you have a 4-month versus you didn't resect, you got a complete response.
I often go back to platinum with PROC patients, obviously, but in this setting, but not right here.
I got you.
Yeah.
I was going to say, would anybody do dose reduction on BEV?
That's a great question.
I knew it.
Well,
I knew it. There we go. We got people.
It depends on, I think it
do.
depends on the
If
clinical
they weren't
Thank you.
progressing.
Yeah.
What about Trodacorbin and Nabraxane?
That's what.
Of course.
Yeah. So the answer is why not Rosella? Okay.
Yeah.
Sure. Well, and she's PD-L1 positive. Why not P96? Okay.
Yeah.
I don't like it.
there you go. All right.
She said I don't like it. All right.
All right.
All right.
Well, that's.
If you're going to say they're not BEV eligible, then you go with the Rosella regimen, because the B96, most.
It was plus minus,
BEV is
yeah.
about-
Plus
Plus minus, but most of.
Most of the patients were treated.
So Brian, how do you talk to your patients about standard of care, and does a control arm? Say you have multiple trials open. Does the control arm matter to you in terms of your counseling, or how you're going to counsel them as to what trial you would advise they go on?
Yeah, no, I think it's actually critically important, especially in this era where we're getting more and more approvals. We'd want the control arm to be the best possible control arm that they can get off a trial. So I think one of the issues is, and I think what you're alluding to is, some of our trials now that have been open for a little while have a control arm of taxanes or taxanes and BEV. But with these two newer FDA approvals, personally, I've had a lot of conversations with my patients who are eligible for trial. I have to explain to them the two possible arms they're going to get, and I also offer to them the opportunity not to be on trial, and I wouldn't give them either arm. I'd give them something else. So it's a long conversation.
Great. Ramis?
And the thing I'll add to that, we live in an era, we saw this with the presentation yesterday throughout the meeting, patients are very empowered to get the state of the science. It's at their fingertips with AIs and their ability to utilize it. I see patients walk in all the time saying, these are the 2 new approved regimens. You're talking to me about a trial. Where is this on the clinical trial, and why is it not an option? So that's something we've got to have a capacity to have a conversation, a dialogue with a patient to help them make an informed decision.
Well, you don't have to be complex. If they've ever searched ovarian cancer, it's popping up their social media feeds, right? You know, I mean, it's just, you don't have to go into an AI.
I'm trying to keep it simple for you.
Yeah.
Okay, all right.
Joyce, what do you think about ADC versus a non-ADC opportunity? Does that play a role in what you want to do here when you have, how do you think about that? We have a lot of ADC opportunities, so what about non-ADC?
I think that within GYN oncology, now that we've gotten comfort with ADCs, that we're more willing to enroll on trials. I think another thing to keep in mind, just when you think about trial enrollment in general, between the phase 2 and the phase 3. Phase 3, right, is standard of care. It gives you this option, but I think the counseling of patients with the possibility of getting placebo or a control arm is a little bit more challenging. Sometimes you have phase 2s where all patients get active drug, and sometimes that's actually an easier sell.
Yeah.
So I think that you really have to think about that too.
Yeah.
But I think
Yeah.
it's really important. It's the phase 3s that are practice changing. So we have to talk to our patients and really impress upon them that, you know, these are really important trials to contribute to. And they would be getting the standard of care, you know, if they got anyway.
Yeah.
Correct.
And I think, particularly with the number of trials we have enrolling, talking about randomization disappointment up front to say, unless you're 100% committed to going onto both arms of this trial, we're not going to do this trial. I had a patient say to me, I'm going to drop off if I don't get the new agent. And I said, I'm not going to consent you. You're done. You're a screen fail, you know? And at that point, I'm sure she probably went down the street, but we need to have that commitment to say this is absolutely where we need to draw the line. So I think we all need to counsel about that. That's a good point. So speaking of options, the NCC had guidelines that update
Lots of
our
options,
options, right? Yeah. And you see that in the platinum doublets. And the platinum doublets and the opportunity for clinical trials, it's impacted me. Because I used to, as you said, Rob, go right back to the platinum Gemzar. But now that's going to take up a line of therapy. But you see their list in the middle, which they've been there for a couple of years now. But we now have the Rosella and the B96 data. On the upper left that's exactly what we talked about with the albumin-bound paclitaxel and relacorilant. On the right, under useful and easy for me to say. I swear this is water. Useful in certain circumstances. Woo! I told you to do this part.
Columbus,
CPS greater than or equal to 1, that we have the B96 regimen with plus or minus Bev, to Brian's earlier point. So lots of options for our patients, but we now have survival advantage. And I think that's something really we need to consider. So looking forward, we've already started a really robust conversation about how much are these survival advantages impacting us. She would not have met the criteria of Mirasol, right? Now, we talked about the option, but the relacorilant and the Rosella and B96 data, this is what we're doing. Yes, cross-trial comparison is not okay. What do we all do? Cross-trial comparison, okay?
What are you going to do?
You know, so again, these aren't the exact groups of patients. MERV was a couple years ago, but I think it gives us a sense that the weekly taxanes seem to behave similarly across the board, both in Rosella and B96. And it's important that the B96 objective response rate included those 75% of patients who have received Bev. Now, we know that we have now I'm struggling here. The 2 approvals really within a month and a half of each other. This is a great option for our patients. It's made all of us rethink how are we approaching the patients with weekly taxanes. What else has it impacted? Our decisions on clinical trials. Do we feel comfortable putting that patient on a weekly taxane regimen without Bev or relacorilant or Pembro? And I think we need to ask those questions, being open and honest with a shared decision with our patients as we approach these decisions. So I look forward to a robust conversation, but let's not forget the opportunity, as I said, for clinical trials. Both biomarker selected, not selected, ADCs, non-ADCs. If a fair amount of your patients are getting ADCs in the first or second line, you're going to need non-ADC options. We should all have at least 2 platinum-resistant ovarian cancer trials open, paying special attention to the number of prior therapies, thinking about that in your sequencing. I'll turn it over to you, Tom. We know lots more are coming. We've alluded to this on multiple times, and we really need to keep respond to your emails, please. We got so many options. Just need you to tell me if you're interested or not.
All right.
More than one.
Let's see where we are here.
All right.
Thanks, Dave. Thanks, Ramez. Appreciate it. And going to turn it over to you, Rachel, to hear about low-grade serous.
Well,
Right.
want to talk about Rosella first?
Oh, okay. Rosella.
Yeah,
that first.
I would love to talk about
All right.
Rosella.
Well, I know that.
Rachel, you're up anyway. You're up next.
I mean, we're ready. Lucy
Yep.
Gilbert did a great job at ASCO talking about this impact on on the previous paclitaxel. Now, we don't know. This is not weekly paclitaxel, but the impact on weekly paclitaxel in the resistance setting. So what did it show? And Lucy, again, beautifully presented it. It did not really impact the benefit. You see the hazard ratio very consistently 0.65 plus or minus. So depending on when you recurred after your exposure to the taxol-free interval, did not seem to impact the benefit of these patients. We've talked about the ADCs and the evolving landscape. In the single agent, very consistent, about 50 to 55% plus or minus 5%. Here we have the trials, where they were presented in the far right. And again, looking at the objective response rate in these single agent trials, we see a slight increase if we use them in combination, but really 50% plus or minus about 5%. So now we get to the PROC discussion, and we'll go from there.
Let me start with Rachel, seriously. So in terms of what do you do with the weekly taxane backbones, how do you sequence that in? I know it's probably some individual thought there, characteristics of the patient and what they've had prior, but neuropathy, et cetera. But how does that work for you?
Yeah, thanks, Tom. Similar to what Dave just said, I've really learned from these studies that I do need to be using my weekly taxanes earlier. Historically, I had kind of saved them for longer. And now that we have overall survival advantage from 2 studies, the Rosella regimen and the B96 regimen, we owe it to our patients to be thinking about using these as soon as the patients are eligible for them. I think I look at the patient if they're PD-L1 positive or not. I look if they're Bev eligible, and then I make the decision for which weekly taxane regimen is best for them. But I'm using them much earlier than I was before now that we have this overall survival data.
Okay.
And you said something really interesting when we were just sitting around talking before. At what point in solid tumor oncology have we held back our best regimens and patients did better?
And waited.
Yeah.
Right? Using them earlier it seems to have the greatest impact.
Totally agree.
I mean, we've already had one trial flex its requirements to requiring a weekly taxane, right? And I think that more will probably need to follow because FDA considers this available therapy.
Bob, now how do we decide between Rosella and B96? What are the things you think about in terms of patient characteristics that push you one way or the other?
Yeah, so B96 was 1 to 2 priors. So if the patient was earlier in their course, I would think about using the B96. And since we have data that prior taxane use
Just if they're second line, you would always use B96 and not Rosella? I'm just trying to...
No, I'm saying, and also since we have Lucy's data saying that prior taxane use did not impact efficacy, I could use the Rosella data later.
Katie, I think a lot of people use Mirasol, though, more than 3 priors, right? I mean, I get it, Bob. That's a great point, and I do the same thing. But I think now that Mirasol's been around a lot longer, I see people using it 4th, 5th line, although that may technically be off-label. I'm not sure that really matters.
Well, I'm not sure we can say that. I do think it's happening because people are catching up. It's a new approval, and so you're finding your patients whose tumors are folate receptor alpha high and using the medication where you find it. And that could be fourth, fifth line, because remember, it was 1 to 3 priors, but what if someone had 3 or 4 platinums and then were platinum resistant? Well, of course you're going to use it, in that setting. So yes, I think that's true, and yes, I think it will continue to be true in that sort of a setting. In the pure platinum-resistant setting, though, at least from the phase 1 study that Dave and I are both involved in, the efficacy does decrease in multiple lines of platinum resistance. So there is a correlation with efficacy with mirvetuximab efficacy, both on folate receptor alpha expression as well as number of lines of therapy, which is why we restricted it to 1 to 3.
Right.
When we got out 4, 5, 6, did it work? Yeah, it worked. It just didn't work quite as well. So I do think there is some association with, like everything works better the earlier you use it.
Right.
So I don't know if it's any more pronounced, but.
And to be clear, the reason B96 is 2 priors because it carried bevacizumab with it, and bevacizumab is 2 priors because of the I don't know if it's theoretical or not, but the indication. The indication is 2 priors because of the concern over GI perforation. You had a comment?
Yeah. So the one thing that we brought this up also at the educational session, the kind of the clocks when a patient hits the platinum-resistant setting, actually even in before that, but the clock kind of starts, and you lose efficacy, and you also lose patient volume with every line of therapy. So that's
20%, Rob?
Yeah, 20 or more,
20%
or
plus
more.
drop-off.
So I think that you got to keep that in mind when you're strategically planning, knowing that you're going to be looking at multiple lines of treatment. That's when that planning should start. And these are all of the things the nuances about how you're going to sequence these effective therapies. I think that becomes part of the dialogue.
Yeah. And interesting, like the MMA, so the DM payload for MERV did show maybe a drop off in efficacy, but the topo payloads appear to have about the same efficacy with multiple lines of therapy. I don't know that they've looked as closely as you all did at whether it was resistant line or not.
I don't know that I would agree or disagree with that yet. I think
we don't know
I
yet.
think that all the TOP1 data that's been presented to date has been from phase 1 expansions, and patients who make it to phase 1 expansions with 6 and 7 and 8 priors are very different phenotype than in the wild when we're kind of looking at it. Yeah. So I do think you can get skewed. It may be true, Leslie, that may be true, or it may not be true. But we're basing these statements based on 40 patient cohorts.
Right, I agree. We need more data.
And so I think we need more data.
Well, speaking of Rosella, we have the principal investigator sitting in the first row, and he happens to have a microphone in his hand.
Did you bring your own?
Just a quick comment. I'm sorry. Professor Potori's comment is what I wanted to react to. Yes, taxane prior exposure did not affect efficacy on Rosella, but it's important to remember that Rosella excluded people that progressed on weekly taxane.
Correct. That's right.
So, I think with regards to, if my patient comes into me and she's primary platinum resistant.
Primary, yeah.
Primary, and I say, oh, this drug that you just got 3 months ago, 4 months ago, I'm going to give you again, but I'm going to give you a weekly. Mm-hmm. They're going to run out of my office screaming. So I'm not. The odds of me using weekly taxanes in that primary platinum resistant for me is pretty low. And I'm sorry.
Could I point something out though?
Of course.
So the GOG study.
Try how I'm wrong.
Oh yeah, that was a given.
So the GOG study that Rob and Mark Shaheen led, looking at weekly nab-paclitaxel, it was in the primary platinum-resistant setting.
That's exactly right.
That was the first treatment these patients received, and in fact, the treatment-free interval for those patients from their primary treatment was on average 21 days, which is crazy. And the response rate was still like 23% there. And so, I do think we have data showing that somewhat amazingly, even just nab-paclitaxel by itself is quite effective in that setting, even though it doesn't make sense.
Rosella included those patients, and the addition of relacorilant was better. So I don't disagree, but they did include those refractory patients, whereas a little bit of a differentiator.
3 months.
We love the interaction.
3 months, correct. 3 months.
I think we have another question from
over here. Comment.
Hi. So, Dave, you mentioned when you're consenting patients for randomized phase 3 trials, one of the things that you try to avoid is a patient that's going to drop out if they randomize to standard of care. I'd like to know from the panel, can you guys give us some advice for how to counsel patients pre-trial enrollment. I mean, what do you say to people? I mean, how do you justify being randomized standard of care when a lot of us fully believe in some of these new ADCs?
Go ahead, Brian. You brought that up.
Yeah, no, I think it's a great point. I think it's part of it's going to be the conversation and their responses. Part of it, truthfully, is how you perceive them to be. For example, if a patient's traveling 4 hours because they want the new ADC that's in a phase 3 trial, you tell them, are you really going to travel 4 hours to get weekly Taxol? And they may say yes, but you really have to, you get to know the patient and see, because the last thing we want to do, and we'll ruin the integrity and the data in these clinical trials, is to get people to drop out of the control arm because they're, of the randomization bias.
Yep.
But the bigger issue to me is, are you comfortable with single agent weekly taxane in that patient? And if she says, there's no way I'm losing my hair and there's no way I'm driving an hour, then are you comfortable with single agent PLD or weekly topo or GEM? So I think for me, utilizing the regimen which has survival advantage, if it's MERV or if it's weekly taxane regimen, and then offering them that trial or the next trial.
But as you've alluded to, if the trial doesn't give Rosella or B96, why would I get weekly PAC when I can get NAB-PAC, relacorilant, or Pembro? So lots of complexities.
Can I say one thing about this case? One of the things that we often talk about is B96 or Rosella. Don't forget, these are durable patients, right? And there's definitely an opportunity. For example, this case, I may start with Rosella, then I may go to MERV-BEV, then I may go to, she's platinum eligible, then I go to a platinum-based regimen. And then I can go to B96, right? So I think the fact that there's
3 months ago, Brian.
What's that?
She died 3 months ago.
In your practice, you're still treating her. No, she moved to Florida 2 months ago. She's seeing me in my practice.
There you go.
All right, so that was fun.
So
we got follow-up.
One more
follow-up question. So, but if you have to do all that, then they're not eligible for the trials because they only allow 1 to 3 or 1 to 4 priors. So how are we supposed to deal with that?
No, I think you're right. I think that the counseling up front needs to be very explicit. I think you need to try to be as clear as you can as what the detriment is of doing that exercise, randomizing and then coming off. That's a huge influence of bias on the trial, and it makes it uninterpretable. So if they're wanting to participate because they want to change the standard of care for the future, they've actually done the opposite.
The argument for the control arm that has resonated the most with my patients has been that the sooner the trial is done, the faster the drug will be available commercially. And if you don't get it in this setting, there's a chance that you could get it commercially in the future, or some similar drug could be available because we just need to get these trials done. That's resonating.
If they drop out, if they get on the control arm, is that worse, or is it worse to have a trial that allows for crossover at progression? I know in some of the trials, my patients, they really like that because they're like, oh, bummer, I got the control arm. But if this doesn't work, I still get a second shot. And I'm just curious, is it such a burden? Is it more of a burden than for people to drop out if they get control arm?
I could show you a graph of what the amount of bias that's introduced into a study based on the number of crossover, of dropout per trial. It's much better, and it's because you can plan for it in the statistical design for crossover.
The hesitation.
So why are they not all crossover?
I was just going to say the hesitation is because OS is what matters. In PROC generally is the metric, and so the people that design these trials, maybe these guys, they're concerned if they cross over, they may not contaminate the endpoint.
One last question from deep right field. Warning track. I thought I saw someone wave.
Is that by the bar? Oh, no.
Do we not have a question? Someone was raising their hand.
There's one over here.
It was her.
All right, so
we got it.
So if we know anything,
we got over here.
All right,
left field.
All right.
Oral Cytoxin, Pembro Bev. We haven't mentioned that regimen. Where does that now with B96? Are you guys using oral Cytoxin, Pembro Bev? And if so, do you use it before or after B96?
I love it.
I'm waiting for the energy trial that we discussed today.
I mean, B96 is, I think we're, to Brad's point, we're going to use it all over the place. Does it matter? Is that the reason, the magic reason it was positive? The only positive study was 1 to 2 and you didn't have T-cell exhaustion? I don't know. Yeah. But, you have a lot of patients. You have patients that are 3rd and 4th and 5th line, and they may or may not be PD-L1 positive, but they're outside that label, and they have neuropathy or whatever. I'm, of course, using that regimen. I think it's a great regimen. I do hope the study moves forward. I don't know if it will. But that's where I'm going to use it. And And the thing we don't have time to talk about, because I see Tom getting edgy about time, legitimately, because we have a lot to cover. It was like ovarian today. And I mentioned this in ovary today. There's a lot of patients who are, whatever your definition is, are taxane ineligible. Either they just don't want it, or they have real neuropathy or other reasons. And I'm going to use it there, for them. And that's not a small population. And the data from B96 is compelling, but if someone has grade 2 neuropathy, is it compelling enough to make it worse? I think that's a discussion between our patients and us. But I am going to still use that regimen. I think it's a very nice alternative. It's probably not as effective, though.
But thank you for bringing it up. That's an important, it is NCCN listed, and we appreciate it. Let's move on. If
We're going to Rachel now. Low grade.
As I said,
serous.
if we know anything about our cancers, is they're heterogeneous. So we've tried to partition them in from our high grade serous, obviously now low grade. So take it away, Rachel.
Thank you, Brad. Well, thank you for inviting me tonight. It's always an honor to present at the highlight reel. I would note that the original agenda for tonight had low-grade serous ovarian cancer coming first. And one of my good friends here put on the slide deck, we want to start with a bang, so let's start with high-grade serous ovarian cancer. But I would argue that low-grade serous ovarian cancer is really having a moment now.
Yes, it is.
And is equally exciting. I'm also, really happy to say that our first FDA-approved regimen specifically for this disease was approved last year, avutometinib and defactinib. Earlier this year, Dr. Amanda Fader presented the results of the pivotal phase 3 study that really defines our adjuvant therapy for this disease going forward. And I'd say right now we're seeing a level of industry interest and engagement in development of targeted therapies specifically for patients with low-grade serous ovarian cancer that is higher than I've seen in my 15 plus years of studying this rare disease. So I think it's a really exciting time to keep that momentum going and continue to improve outcomes for patients with this disease. We're going to start by going straight into a case, and we do have some audience response questions incorporated in here. So we have a 34-year-old woman who presents with 6 months of pelvic pain and bloating. She goes to her PCP. He refers her to a GI. Upper and lower endoscopies are unrevealing. Her pain persists, so she goes to the emergency room, where a CAT scan unfortunately shows that she has bilateral adnexal masses, pelvic ascites, and bulky omental disease. Her CA-125 is found to be elevated at 175. Inhibin B and CEA are within normal limits. She undergoes a paracentesis, and the cytology from that does show malignant cells that are PAX8 and ER positive, consistent with ovarian cancer. So she sees a local oncologist, and they recommend that she start neoadjuvant chemotherapy with carbo, Taxol, and Bev. So what would you recommend for this woman at this time? Should she go forward with neoadjuvant chemotherapy since she's symptomatic from her disease? B, should you delay therapy and refer to a gynecologic oncologist for consideration of primary debulking and or laparoscopic biopsy? C, refer for IR biopsy? Or D, order a PET scan?
So this is our first Slido. If you can right there, download it on your table and go ahead and vote now, and we'll look at this at real time. I think we put this as we say a softball, because I think this is pretty straightforward. So let's get warmed up. Can you go ahead and show the vote here?
It's not working.
Showing.
Oh, no.
Oh, there it is.
There we go. It's just-
There it is.
All right.
All right.
This is the low-grade serous.
So I give radiation. Oh. Okay.
It is the low-grade.
So we're going to keep moving here, but that is, again, we're gynecologic oncology specialty. Surgery is still relevant, at least for now, even in low-grade serous cancer. So we're just going to keep rolling here. So go ahead, Rachel.
Yeah, so we really need that tumor tissue, first of all. So even if this woman is not going to have surgery, we know that cytology is not enough anymore for any type of ovarian cancer. We need that histologic diagnosis. We might suspect this woman has low-grade serous ovarian cancer based on her age and relatively low CA-125, but we need some tumor tissue, not just cytology, in order to make that diagnosis. And then on top of that, after the diagnosis, of course, we have biomarker testing that we need to be able to do. And we need a real piece of tissue to do that. And if we treat our patient based on just cytology, they are missing out on an opportunity to get the most effective therapies. But apart from that, since we suspect this woman may have low-grade serous ovarian cancer, it is especially important that we give her the opportunity to be evaluated for a primary debulking surgery. Because we know that neoadjuvant chemotherapy in this scenario has dismal results with response rate generally less than 10%. And that complete cytoreduction is the strongest predictor for overall survival for this woman. So she sees a gynecologic oncologist and undergoes a laparoscopy, where she's found to have disease amenable to primary debulking. A complete gross resection is received, and her pathology is consistent with stage 3C low-grade serous ovarian cancer. She's otherwise healthy, has good social support, and is recovering well from surgery. So what adjuvant therapy would you recommend for her at this time? Carbotaxol Bev followed by Bev, carbotaxol followed by letrozole, letrozole alone, or observation?
Yeah, go ahead and vote now. The questions are getting more complicated. Let's pick on you guys down at the end of the table here. Bhavna, what do you think is a good answer here after adjuvant primary debulking for LGSOC?
Yeah, based on the data that Dr. Nichols-Fader presented, I would go with the IV carboplatin paclitaxel followed by letrozole.
So Joyce, not letrozole alone? She's young. She doesn't want to lose her hair.
You can't bully me into the wrong answer there.
Let's go.
Good girl.
I'm sticking to my guns. Like, go with the data, a little IV carbotaxol followed by letrozole.
Okay. Any comments on that, Rachel? We'll keep moving.
I completely agree. We do have retrospective data from MITO 22 to support carbotaxol Bev followed by Bev. But I agree, in the United States, our standard of care is carbotaxol followed by letrozole. And it is so important that this study was conducted because we've seen increasingly over the past 5 to 7 years, women with advanced low-grade serous ovarian cancer receiving letrozole alone in the adjuvant setting. And that was based on some retrospective studies, but not based on prospective level data. So it was such an accomplishment of Dr. Fader to complete this randomized phase 3 study that was able to give us a definitive answer for what is the standard of care for adjuvant treatment in this setting. So GY019 enrolled women with advanced low-grade serous ovarian cancer who had undergone a primary debulking surgery, and then randomized them to treatment with carboplatin and Taxol chemo for 6 cycles, followed by letrozole maintenance versus letrozole maintenance alone. And this was, of course, designed as a non-inferiority study to see if letrozole by itself could be non-inferior to chemo followed by letrozole. And it was found at the time of the second interim analysis that the study had met its pre-specified futility for early stopping, pre-specified criteria for early stopping due to futility, with a hazard ratio of 1.3 for the overall population. Now, we don't yet know what the median PFS is, as the number of events has been rather low, but 77.9% of patients treated with chemo followed by letrozole and 71.9% of those that were treated with letrozole alone remained alive and progression-free at the time of this analysis. And I think we got these results a lot earlier than we thought we were going to. We thought we were going to have to be waiting years for this answer. But this really does give us a definitive answer about what the standard of care is right now for these patients. There was a pre-specified exploratory analysis looking at those patients who had a complete gross resection, which showed a smaller difference in PFS with a hazard ratio of 1.15. But that is exploratory. We'll continue to learn more about that over time. For now, we have a clear answer as to what the standard of care is. So this patient is treated with carbotaxol, and at the end of treatment, she starts treatment with maintenance letrozole. After 3 months, her CA-125 starts to inch up, and then at 6 months, unfortunately, she's developed radiographic progression with disease not amenable to secondary debulking. We look back at her initial pathology and see that her IHC testing showed a low rate of folate receptor alpha positivity. She was PD-L1 negative and HER2 0. She has a liquid biopsy performed that shows no mutations. So what would you do for this woman at this time? Would you A, submit her archival tissue for NGS sequencing, even though she already had a liquid biopsy? B, start treatment with carbo-liposomal doxorubicin plus or minus Bev? C, start treatment with MIRV, even though she's low folate receptor alpha positive? Or D, submit her tissue for MMR testing?
She only had liquid biopsy.
Yes. Which was negative. So Rachel, while they're voting here, does that surprise you? 3 months? That's not very low grade. That's not very indolent.
Yeah, well, we see different types of low-grade serous ovarian cancer, right? And I really, I don't love how we use that word indolent to describe this disease because these women mostly present with advanced stage disease, which they ultimately die from. And so, we have some patients that it takes a long time to recur, but on average, they recur within the first 2 to 3 years, similar to high-grade serous ovarian cancer.
So again, I think this is straightforward. 100% of our audience says submit her archival tumor tissue. I think as you and others have taught us, if the liquid is positive, it's positive, but if it's negative, which is a relatively frequent occurrence, it's not really negative.
Completely agree.
And what are you looking for in the archival NGS?
Yeah, so I'm looking for, does she have a V600 BRAF mutation? That's present in 6 to 8% of these patients. And of course, we have an approved combination therapy for patients that have that mutation, dabrafenib with trametinib. And then I'm also looking to see, does she have a KRAS mutation? Now that's more prevalent. That's found in a third of patients with this disease. And of course, we have an FDA-approved treatment for that. But as Brad was saying, we now have prospective data showing that amongst patients with measurable disease, only 32% of these patients will have detectable ctDNA by liquid biopsy. So it's really not a reliable way for us to be finding out the patient's somatic mutation status. And if we're using that to try to determine if somebody has a KRAS mutation, 56% of the time it's going to have a false negative. But I can't tell you how many times I have a patient who I see as a second opinion where that's the testing they've had done and it stops there. But as we were saying, this is incredibly important because we now have an FDA-approved treatment specifically for patients with a KRAS mutation based on the GOG 3052 RAMP 201 study that not only showed a 44% response rate for patients with low-grade serous ovarian cancer treated with avutometinib and defactinib, but the really remarkable thing was the amount of time that patients were able to stay on treatment and the duration of response, with a median PFS of 19.6 months and a median duration of response of more than 31 months. So we need to know if these patients have this mutation so they do not miss out on the opportunity to receive this medication. So for this woman, we do her NGS sequencing, and we find that she does have a KRAS G12V mutation. So we talked to her about the expected efficacy of chemotherapy in this setting, where we generally see a response rate of 13% or lower. Endocrine therapy would have a very low response rate in this setting where she's already progressed on letrozole. And then we look at our options for targeted therapy. So we have avutometinib and defactinib, which is specifically FDA approved for those treatment of those women that have a KRAS mutation with that median PFS of 19.6 months and median duration of response of more than 31 months. Though it is important to note that that study showed activity both in wild type and mutant patients. And the ongoing RAMP 301 study will hopefully give us more information about the relative activity of that combination in the wild type patients. Now, we also have the option of single-agent MEK inhibitor with binimetinib or trametinib. Now, neither of these drugs is specifically approved for patients with low-grade serous ovarian cancer, but they are both compendium listed for treatment of that disease. And while they're listed for all patients with low-grade serous ovarian cancer, we do know that those patients that have a KRAS or MAP kinase alteration have higher response rate and better PFS than the overall population. Though, we don't really see as long of time on treatment as what we see with avutometinib and defactinib, and that's probably multifactorial, both efficacy and tolerability. And then an emerging treatment option would be treatment with a CDK4/6 inhibitor in combination with endocrine therapy. And that's based on the results of the GOG 3026 study led by Dr. Slamovitz and colleagues that showed that the combination of ribociclib with letrozole had an overall response rate of 30.6% with a median PFS of 14.5 months. So I think these are all potential options for this patient, but based on those really durable responses that we saw in the RAMP 201 study, I think I would recommend avutometinib and defactinib for this woman.
So I'm going to open it up to all of you and let you volunteer. Who has used this regimen in their LGSOC patients? And tell us, a lot of us. So that's, wow, okay. So I'm just going to let somebody chime in. What are the challenges that you see from an adverse event perspective? Dave, why don't you go ahead since I'm looking at you.
Yeah,
and how do you deal with that?
Yeah, I think what's interesting is the MEK inhibitors, as we know, can be challenging with regards to the dermatologic, the edema. But with the combination and the intermittent dosing, it's actually was better tolerated in a combination therapy, which I don't say very often. So in a lot of ways, to your point, the combination treatment has less side effects. Again, this has never been controlled, but from a standpoint of the day-to-day tolerability of the regimen, educating the patient about the schedule, making sure you're sticking with the schedule, it's well tolerated.
Antibiotics, steroid ointments.
To help the dermatologist.
And Bob, tell me how important, or any of you on the left here, how important is interruption, recover, and maybe even some dose reduction, because there's some option. Is that, I guess I'm concerned that individuals are going to get it, have an adverse event, which happens, and bail on it too soon.
Yeah, I think with any therapy, it's really critical to, hold the drug, let patients recover from their adverse event, and then restart it if you think it needs to start at a lower dose. But it's very rare that I, discontinue with therapy.
And see the eye doctor, right? And okay. Any other comments about LGSOC?
It's more monitoring, right? The lab. Sorry.
Jubilee has a question.
Jubilee?
It's not a question.
Or a comment.
So you got three people. So Jubilee, Leslie, and then over here, I think Brian. So Jubilee.
No, just some real world experience, right? So to your point, Dr. O'Malley, the trametinib, honestly, in my experience, has been really hard to manage just because of the rash is just so bad.
Right.
Yeah. And so even though I have a talk where I show mass goes away, ascites goes away, but the reality is this poor patient had just such awful skin toxicity that she kind of became a little bit of a hermit, right? Okay, fast forward to avutometinib defactinib, and this is very well tolerated. Like my real world experience, I have a patient who, she's just lovely. She has fairy hair. She's vibrant. And she had some fatigue. So we stopped for a minute and then we came right back in and she's tolerating it great. And she's had a near complete response in under 2 cycles.
God bless her. Thank you. Leslie, you had a comment, and then we'll come over here.
Oh, just lab values.
Yeah.
So
Yes.
CPK,
CPK,
AST, different, and then often they'll go up, and then you can hold and start back at the same dose.
GI toxicity.
Or just treat through.
Straight through.
I just wanted to offer, so I had a patient and she had in just her lab abnormalities, no symptoms, but her CK came back at over 5,000.
Yeah, it has. Yeah.
And so then she ended up coming in and was hospitalized for almost a week just as we trended it down. And I reached out to Rachel, who was gracious enough to kind of counsel. And I just wonder what you guys would do in terms of re-challenging, or if you're dose reducing or not going to go back to it.
Interruption.
I think interruption, dose reduction.
Interruption.
Exactly, yeah. So for a grade 3 or 4 elevation, of course, we dose hold, as Joyce did. For grade 4 elevation, you can consider permanently discontinuing. For grade 3, we usually resume. And then, of course, the counseling for the patient is to stay well hydrated and to not start any new vigorous exercise activities to try to stay at their normal exercise rate. We definitely see it go up with vigorous activity.
One quick comment. I really like Amanda's study we talked about, and it's in the control arm. Our treatment arm is still carboplatin and paclitaxel, 5-biletrol maintenance. But it was a great study. Maybe it's just a wrong experimental arm. We use letrozole. Lauren Cobb and Gersh did a neoadjuvant study of CDK4/6 with fulvestrant. They had a 47% response rate in the neoadjuvant setting. So maybe changing letrozole into something more active may be the way to get rid of chemotherapy in this disease.
It's been proposed,
Yeah, and we have a study looking at that right now, Brian, a neoadjuvant study of avutometinib, defactinib, and letrozole in the neoadjuvant setting that we're hoping, could be a potential replacement.
Question, comment.
So I have a question. Have any of you found an indolent polymyositis or anything? We had a patient who we were looking for starting avutometinib, defactinib, and found a polymyositis. Thankfully, rheumatology consulted and said it was appropriate to start because she was non-symptomatic. But I was just wondering if you had any with routine CPK prior to starting, had found that.
So how did your patient do?
She's doing well. We did have to dose reduce for LFTs, but otherwise she's doing well.
Yeah, so I think these special cases like this, we learn about these in the real world setting, right? Because you're not going to necessarily have control for that in the study. It is interesting. In the study, we didn't routinely look at myoglobinuria before you went on study. And some patients are positive for that before they go on treatment, or have an elevated CPK before they go on treatment. And sometimes it still doesn't change very much once you're on treatment. So I wouldn't necessarily consider that an exclusion. Like you did a thorough workup and informed the patient. But yeah, that's how we get this real world experience, is seeing how these patients do.
And multidisciplinary care, right? Having a rheumatologist now with all the IO, having that rheumatologist on board who you trust, who you can have a continual dialogue.
All right, we're going to move on to endometrial cancer.
One more, Rebecca.
We're trying.
So I had a patient who just the eye toxicity is real but manageable. Within 18 hours of starting the drug, she was in ER with pigment epithelial detachment, and it was real.
Oh.
We stopped the drug and restarted it 2 weeks later at the first dose reduction, and she had a great response. Stayed on the drug, so we re-challenged, and it was a victory. But it was very scary within 18 hours that she couldn't see.
Sure.
Yeah, that's
And that is, if somebody's going to have ocular toxicity, it most commonly occurs within the first 48 hours after starting the drug. And so that's why it's so important that we counsel our patients about that's when you really are going to expect it, that first week of treatment. So they're looking out for it, they know to call you, and they're comfortable with restarting, since most of these patients actually can be restarted, as yours patient was.
Yeah, and I think that's an important teaching point for the people in this room, because I think if you get a phone call within 24 hours, a lot of you just started the drug, there's no way, but it was real.
Yeah.
All right. Thank you. That's an important clinical pearl. All right, we're moving on to endometrial cancer, and we're going to, leading this session will be Dr. Slomowitz, Dr. Pathori, and Dr. Barlin. So, Brian, take it away.
Thanks. To Rachel's point, I think the more, as we go through the program, the more important cancers are being presented. So, I agree.
That ends up with you guys.
Leslie, you're going to have a lot of great things.
Crescendo.
We're actually behind, so keep moving.
every once in a while you're funny.
Yeah, exactly.
Wow, Dave said that. I'm relieved. Thanks, Dave. No, guys, let's keep us on track. No, thanks, Dave. So I think we're going to present some two good cases, but before we get there, I sort of want to highlight what we're doing here tonight, the highlight reel, some of the data that was presented at the meetings from this past season, and a teaser. The data that we saw last couple of months was good. Wait till the fall. The fall and endometrial cancer, we're super excited about a lot of the findings that, a lot of the data that we're going to hopefully read out on. So, I'd say in endometrial cancer, the spring season was really about DMMR tumors, reconfirming a lot of things that we've learned. This is a study that, this is the Ruby trial data. Matt Powell presented it both at the SGO and a further update at the ASCO, really showing the long-term benefit in the DMMR setting, the DMMR patients treated with the dostarlimab. They did what they call a conditional survival analysis, which shows, just to highlight in the box on the right, after 1 year, the 3-year landmark of disease-free was overall survival was 84%. After 3 years disease-free, the probability of being alive is 95%. So really, it highlights a couple of things. One, the long-term benefit. Okay, but secondly, maybe it'll give us some answers about how long we really need to keep the maintenance therapy. If we're getting all the activity in 1 or 2 years, maybe that's enough. I think the future of that will really rely on further studies looking at ctDNA in this setting to really highlight maybe the need for maintenance setting and the length of maintenance setting. I think then also at the ASCO meeting, our colleague Ramez Iskander presented a follow-up in the DMMR setting in the GY018 Keynote 868. And similarly, they found that in the DMMR population, patients did well. The patients did well. Here we could see the survival at 48 months in those patients treated with pembrolizumab arm. They had a 78.6 survival versus 60.4, hazard ratio 0.54. Again, it was a little bit more difficult in this study because overall survival was not a primary endpoint. The study ended, remember, once the PFS mark hit. So, but it's still promising data. And amongst the participants receiving post-study therapy, 93% of patients in the control arm did receive a checkpoint, again, highlighting the importance of treating earlier on with a checkpoint inhibitor in these DMMR patients. Then at the ESMO GYN meeting in June, Bob Pathori presented the follow-up data, the 6-year follow-up data on Garnett, showing that the response rate remained the same, but 9 patients who had partial responses converted to CRs. The long duration, the more effect you can get. Again, highlighting the importance of checkpoint inhibition, in the DMMR patient population. This is exciting. This is something that we're all proud of. This is looking at Keynote C93. If you remember, this was looking at DMMR, getting rid of chemotherapy. Patients were treated with pembrolizumab versus chemotherapy. The first comment you'll say, which is true, the control arm, wait. We've changed since the study started. The control arm here is carboplatin paclitaxel. Doesn't have the GY018 regimen, but again, there's a lot to learn, I think, from this study. This followed along the lead of Keynote 177, the colorectal patient population, showing that pembrolizumab can outperform chemotherapy in this setting. Something that we're excited about earlier this week, there was a press release. Again, we do not know the magnitude of the benefit yet, but there was a press release showing that in the DMMR patient population, there was a statistically significant advantage in progression-free survival in the DMMR patients who were treated with pembrolizumab. Super exciting. Again, teaser for in the months to come, when that data is presented, what's the magnitude of benefit? Finally, at ESMO GYN, there was a NIVEC trial that was presented. It was really a proof of concept study giving immunotherapy prior to surgical intervention. What they found is 68% of the patients had complete clinical response, 32% of major pathological response. Ultimately, 7 of the patients did not need surgery. So again, in a neoadjuvant setting, there was a tremendous response rate. We saw similar data in colorectal cancers as well, highlighting the importance of immune checkpoint inhibitors in the DMMR setting. This is the laundry list. This is a 2-hour talk by itself, but we're not going to go there. This is a laundry list of the activity data of antibody drug conjugates in endometrial cancer. I want to highlight the TDXD on top, the overall response rate of 57%. It's an active drug. The FDA approval for TDXD based on the Pan-Tumor Destiny 02 trial, 85% in the 3+ population. TPAM, Bhavna presented and Katie Moore presented, overall response rate of 48%. That's another HER2 ADC. In the 3+ population, 73%. The TROP2 ADCs, SAC-TMT, sacituzumab govitecan, and Dato-DXd, all with activity. Again, another teaser, press release, SAC-TMT is a positive trial for the trifecta, overall survival, progression-free survival, and response rate, soon to come at a meeting in the future. The B7H4s are active, both the AZD 8205, MORAZ, and also RENA-S, the folate receptor alpha, with 50% response rate. Hormonal therapy, again, we're looking at in this setting, in endometrial cancer, not only in low grade, but looking at the CDK4/6s in endometrial cancer. Marilyn Wong at the SGO meeting and Dr. Silverstein at the ASCO meeting presented their data on CDK4/6 plus hormonal therapy in patients with recurrent endometrial cancer. And without getting too much in depth here, response rates 21%, 39% in Maryland's study, which was a GOG sponsored IIT. Abema fulvestrant, Angela Green, 44%. Panos, 30%. So there's still a lot of data here, a lot of positive data, and I think there's more to come. I will say this has an NCCN listing, so getting this assets for your patient is a possibility. One interesting study that Lucy Gilbert presented was, what about treating with giredestrant, which is a next generation oral SERD, prior to surgery in patients that aren't surgical candidates? Lucy presented this at the SGO meeting, and what they found that the 6-month tumor regression rate in all evaluable patients was about 82%. 6-month tumor regression in premenopausal women, 90%. Again, proof of concept, something to look forward to. Maybe treating with the SERDs in the neoadjuvant setting, pre-treatment setting, can reduce the disease, and fertility preservation may be a better option for some of these patients with early endometrial cancer. Last but not least, the GLPs. There's a lot of data, more and more data coming. It's not just an obesity drug, it's going to be an anti-cancer drug. This was a study that was published in JAMA Network showing that patients treated with GLPs have a lower incidence of most cancers, except kidney cancer. I'm not sure why, but the lower hazard ratio was seen in gynecologic cancers. And in this spring, there was one retrospective cohort study showing patients treated with GLPs and progestins had a decreased risk of needing a hysterectomy when they were diagnosed with hyperplasia or earlier stage endometrial cancer. A lot more to come on that. Thank you.
Thank you, Dr. Slomovitz. That was excellent. Now let's welcome Dr. Pathuri to present an endometrial cancer case. As you see, it's a PMMR and P53 wild type. Go ahead, take it away, Bhavna.
Great. So this is a 62-year-old with postmenopausal bleeding. This was a case from 2008. She had a biopsy that showed an endometrioid grade 1 endometrial cancer, underwent a robotic hysterectomy, sentinel lymph node biopsy. Her pathology returned as grade 1 endometrial cancer, 10% myoinvasion, no LVSI, negative sentinel lymph nodes, ER/PR positive. She had germline genetic testing because she was only 40 when she was diagnosed, negative. And she was followed for 5 years, received no adjuvant therapy, given that she was in early stage, and was discharged actually to General GYN clinic. She was a former smoker, and her PCP actually was just screening her for lung cancer and found a gradually increasing left lower lobe nodule that had increased in size. So she underwent an IR biopsy that revealed an adenocarcinoma of Mullerian origin. PET confirmed that it was localized in her left lower lobe. So she underwent surgery with a robotic left lower lobectomy. And her pathology confirmed metastatic adenocarcinoma, consistent with Mullerian origin. It was a small tumor. MMR IHC was intact. She was P53 wild type, HER2 1+, ER/PR positive.
Okay, so what would you do at this point with this patient? A, no further treatment. B, paclitaxel carboplatin. C, paclitaxel carboplatin checkpoint inhibitor followed by checkpoint inhibitor maintenance. D, paclitaxel carbo followed by selinexor maintenance. Or E, Megas.
This is so interesting. Yes.
Wow.
So interesting.
Yeah.
It's a tough case.
Right? It's a good case.
I know. Price is Right.
Yeah.
It's like a horse race.
Just gotta call it.
No, who's going to win? All right. Got a lot of no further treatments. Yep. All right. What do you think of that?
Hormones too. Yeah.
Yeah, I'm
What'd
a
you
no
do, Leslie?
further treatment. Gosh,
Yeah.
I almost never don't treat, but I think maybe in this situation, it's been so long since isolated recurrence. I mean, you have to assume that there's a systemic. How did it get to the lung, right? So that, I mean, that would be the argument for other treatment, but, you know, with the isolated disease, I'd probably just monitor really closely.
Yeah.
And then if I considered any treatment, I would potentially
Is anyone
consider
nervous
hormone.
about this patient? I am.
I would. Oh yeah.
Yeah, I am.
I don't know. Sometimes you have these lung metastases
Yeah.
and these. I mean, I would probably have done adjuvant. I mean, I'm old, so I do Megace tamoxifen. But
Yeah.
I mean, I've put patients on that, and they've just been years. They've never needed chemotherapy. So I would either do no treatment and follow per Leslie, or I'd put her on endocrine. But I would not treat this with chemo.
She was ER/PR positive. Brian, would
She was. Yeah.
Yeah.
So yeah, I would favor. I'm not sure whether Megace, tamoxifen, even single agent letrozole, because you don't need a response here. You need just to maintain that there's no disease. And I would do that because of activity. But another reason why I would do it, if you remember from the chemo IO studies, they allowed prior hormonal therapy.
Right. It doesn't.
So if she recurs after this, you could still give her first line therapy with the same expectations, and you're not wasting the chemotherapy here.
Right.
Good point.
Good point.
Are you guys seeing more of these in your clinic? I think with our improvement of the treatment of heart disease, hypercholesterolemia, diabetes,
Changing
and
the
now
natural history.
GGOPs, many of our patients would have died of their comorbid conditions.
Right.
Because we've gotten better treatment. I've had multiple isolated lung mets and actually recently brain met presenting remote from an early stage disease. And I think we're changing the natural history because we're treating the underlying the comorbid conditions more effectively.
Yeah.
Has anybody else seen those observations?
I just see high grade.
We have someone here.
Regarding the treatment, when you decide to do hormone treatment, you basically decide to do palliative, right? If you give chemotherapy,
Not necessarily.
you're trying to cure, right? If you did a surgery and you wanted to give chemotherapy, the goal is to cure the patient. But then if you give just hormone treatment, then you are saying to the patient that perhaps the goal is just to control the disease from coming, or just to control the disease just now. But you could not say, I wanted to cure, even that she has just one site of metastasis. We know from other cancers, you could actually aim for cure. You could actually get the surgery and give chemotherapy at least.
Yeah, I think that's a great point. But I think we also have to be careful too. Again, talking about the inclusion criteria to the first line trials, in order to be eligible for the studies, you could not have had any other treatments with curative intent. So I hear what you're saying, but actually whether it be surgery or isolated radiotherapy, those are actually curative treatments for this patient. So it's not palliative. It's actually curative, the surgery, and the maintenance, if you're going to give it. I don't disagree with no further therapy. It's an option. The maintenance, if you're going to give it, is not palliation in this patient. It's just to help maintain the cure. So
It's like breast cancer. You could.
I mean,
you can also treat it like hormone receptor positive breast cancer, where you don't use chemo necessarily, unless they're node positive. You have oncotype, correct? And this is not the thing, but it is sort of an analogous situation where you have a hormone receptor positive tumor and you resect it and do some number of years of we'll never have oncotype, and then you can stop it. I mean, she's 68. I think that
62.
I don't know, 62. I don't know. I think giving her 6 cycles of chemo for a lung nodule that you've resected.
It's no longer there.
I don't think I would do that.
Overkill.
But can I just?
But it's not wrong.
You need it later.
Not wrong.
You might give her 3 or 4 cycles. That would be another thing you could do.
Yeah.
I'm going to do
Just
that.
making things up.
Yeah.
But I also think, we don't have data, using hormones as first-line therapy, right? This is essentially like her initial therapy.
No, we
And
do.
we'll never have that,
No, we have.
unfortunately.
We have 3007.
Yeah,
Yeah, but it's a phase 2. We don't have phase 3 data.
We don't have phase 3 data.
Yeah.
We don't have phase 3.
Right?
Yeah.
And
we tried.
Right, we don't have phase 3.
But those
Bob.
were the patients. The patients that were previously unexposed to chemo were the ones that did the best in that scenario.
Exactly.
Yeah.
But I don't think we can sit up here and saying with phase 3 data and having to the point brought up, chemotherapy
It's
and
the standard.
IO, that is a wrong
Good case.
option. That is our phase
It's the
3 data.
standard.
that
Dave,
supports-
she wasn't eligible for the trial.
She was eligible. She went
She had
on trial.
recurrence. Yes, she was.
No measurable disease.
No measurable
No,
disease
if
was
she had
no
surgical
measurable.
resection with curative intent, she's not eligible.
Not
She's a
if
recurrent patient.
She's a recurrent patient. She's
She's eligible, and she went on Ruby.
Well,
You know we're right.
let's hear the rest of the story, Bob.
So the
Heard her.
Here's what actually happened to her.
the patient,
Hypothetical patient.
Should have been giving her tamoxifen. She'd be fine.
See?
so
All right, Bob. You're
all right. So she started Ruby. She completed her treatment only 2 years because she developed a grade 3 pancreatitis. We ended up treating her with steroids, and she resolved completely, but we did not continue the dostarlimab for the 3 years. So she finished 2 years of it. She is now doing well. She was recently seen, NED, and her ctDNA was negative. So, I mean, I think it's a very controversial case, which is why I like it. And it makes you think, right? Yeah. In terms of there's so many different ways that you could actually approach this case. But given that she met the criteria for a clinical trial, and, I always opt for clinical trials in my practice, I put her on and she's doing well. And I think this is also very important that we, based on Ruby, we don't exclude these patients from chemo IO trials because we shouldn't be using that subset data to say that we shouldn't be including P53 wild type PMMR patients.
And this would be a great patient to consider selatexnor if that trial ends up being positive.
Yeah,
to get options,
if it
because the
proves to
wild
work.
type on that, right?
Yeah.
But I think this is again looking at options in this group of patients who are PMMR, P53 wild type. We heard it at endometrial today. This is a different group of patients, a very heterogeneous group of patients that we need to start looking at separately. Probably.
Yeah, definitely.
Yeah.
So, Joyce, what's your standard for PMMR for adjuvant therapy?
The right answer is clinical trial. So
Let's go.
Pick a clinical trial.
She had breast cancer, unfortunately. So now what are you going to do?
I mean, in this case, I think the selinexor, I mean, I guess it's still on trial. So, but, if that reads out, I think that's very provocative.
Yeah. Rob, the trial's closed, right?
It is.
And we're waiting for the data, and you're going to tell us right now.
Actually, and the answer is?
Oh, his mic went dead. Sorry. I think I heard it, but I can't relate it to you. I didn't hear it clearly. All right. Thanks for all that info, Rob, as usual.
Just want to be helpful.
I don't think there's controversy, though, as much controversy, I would say, in a more typical patient that we would see with recurrent disease or de novo stage 4 that's PMMR and SMP. We have phase 3 data from both 018 and from Ruby that would say this has moderate improvement in progression-free survival and no detriment to OS and is a standard of care.
Right.
I think that is like an unequivocal.
So Katie, how do you decide if you're going to use IO in a PMMR patient? What drives you there?
So, I would
do you
talk.
Do it in all, or
I would
most,
talk
or?
to every patient about it because it's driven by phase 3 data, and we have very consistent and clinically meaningful improvement in progression-free survival. We don't have an OS advantage, and so I do think it's the new floor, and then from there we have to do better. The one caveat where I think about things, and maybe we're going to talk about this endometrial group, I can't remember, is if she were TP53 and HER2 3+, I might think about something different. We'll talk about that. But this group, for now, I think it's entirely reasonable to use immune checkpoint inhibitor, but I also think it's entirely reasonable to not and sort of see how they do and use LenPem because there is no OS advantage and you have to talk to patients kind of where they are. I don't think it's the standard of care. I think it's a standard of care.
Yeah, I think that's
DMMR is a different situation.
I think, when we think about the results from clinical trials, and especially in situations like this, if we were in the lab, what would we do? We would take these cells, we'd give it a treatment, and we would see if they died, right? And that would be an immediate cause effect. So when we think about this from the experiment of human experimentation, we're looking for the efficacy of the intervention, but we now have used different endpoints that can be potentially influenced by alternate therapies that happen after progression. That's the thing that always bothers me. And so GY018 or 868, Keynote 868, essentially broke out that group explicitly, this population, and evaluated PFS as a primary endpoint for its analytical endpoint. And I think you have to take that on faith because that was the experiment. Now, we don't have OS, I understand that, and that's still an FDA kind of regulatory endpoint that needs to be addressed. But that was the experiment, and I still think you have to have faith in that standard of care.
Yeah.
I really don't like the word experiment when we're talking about patients.
But that's what it is.
It's a clinical trial. I always tell my patients. I tell patients all the time we're not experimenting.
Let's move on here.
Okay.
All right.
If the patient relapses, what are you going to do next here? Are you going to give her doxorubicin or paclitaxel? Are you going to go with a clinical trial with a TROP2, HER2, folate receptor alpha, or B7H4 ADC? Are you going to use best supportive care? Are you going to use LenPem?
IO exposed.
Or are you going to go with hormonal therapy?
IO exposed.
Ruby.
Yeah.
Right. Oh, look at that. It's changing. Catching up.
I'm really excited to hear about IO after IO by you guys. The overwhelming.
All the data.
Yeah. All the rich data.
Wait till the cervix presentation.
All right, I think we hear it here loud and clear. Thank you, audience. Clinical trial,
Yeah.
love it.
It's great.
God bless.
All right, that's great.
I'm surprised there's not more endocrine therapy, actually. This is an NSMP tumor.
Yeah, fair.
ER/PR positive, yep.
So let's suppose the patient enrolls on a TROP2 trial, tolerates therapy well, and relapses after 9 months on therapy. She has an excellent performance status. What would you do next? Would you now go to doxorubicin or paclitaxel? Would you try to find another trial? Would you do best supportive care, or would you do CDK4/6?
And knowing that it was Bobna's patient, and she enrolls on clinical trials, as many of you do, and as she's the GOGPI of 3095, this is legitimate. Thank you.
But now I'm understanding Katie's point regarding
right
my
hormones.
answer because the less pretreated you are, the better.
But she had a topo 1 ADC already.
Right.
Yeah.
Yeah.
That's true. It's
There we
already
go.
lost.
Now we got it. Now we got some answers.
Yeah, now we have some.
Yeah.
Sequencing is real.
Yeah.
Yeah,
It's really important. It's many options.
Any
as
thoughts on
possible,
that,
right?
Bobna?
Yeah, I mean, I think you're seeing, right, I think these patients deserve some hormonal therapy, and we're seeing that here.
Yeah.
And to Katie's point, probably would have done better maybe if she got it earlier, given the limited data we have that shows better efficacy.
Kind of depends on the patient in front of you, though, right? Because if she's got some nodes that are increasing, you feel real good about CDK4/6 letrozole. If she's got liver mets and ascites, you're going to go with a TOP1 ADC because you need a big whap.
You need a whap.
So,
Yeah.
I mean, it kind of just depends on the patient in front of you and individualization of therapy.
I mean, the other thing we forget in these patients is when the GOG did the sequence of studies of activity, the two agents that were positive were Taxol, which we talk about, but bevacizumab. Bevacizumab works in patients with recurrent endometrial cancer.
That's right.
I think it was like 35%,
Yeah.
which we don't even think about in our mindset, but that's definitely an option for these patients as well.
Correct.
Yeah.
I do.
All right.
So I just wanted to review Joyce is going to review a lot of the frontline trials, but I thought here we could just take a moment to review the open trials that we have in this space, the ADC trials. So these are the first randomized phase 3 trials in endometrial cancer with an ADC. Both of these are TROP2 trials. You heard from Brian already that GOG 3095 had a press release where it met all its primary endpoints. So really excited to see what the data shows. In addition, GOG 3104 is also a TROP2 ADC with SASEG in this setting. So also excited to see what this shows. This is Rainfall 01, actually Dr. Cloven's trial. This was the updated data that was presented. We already spoke about the objective response rate that was seen, which is very impressive, 50%. Rainfall 03 is ongoing, so really help us get these trials enrolled. In addition, we talked about the HER2 ADCs, trastuzumab pamirtecan. This was data that I had presented at SGO, again showing you really nice efficacy with an objective response rate of 49% in prior checkpoint treated patients, and that it has led to FERN EC01 that Dr. Fleur Bacchus is leading. And this trial is very interesting in that the randomization is occurring only in the 1+ and 2+, and there is a cohort of just a single arm cohort for 3+. And then we have MoRes. The Behold 01 data was presented by Anna Oknen at SGO. It was a very small cohort of 12 patients, but did show an objective response rate of 67%. And that you can see on the right is the GOG 3131, which is the global phase 3 trial that's ongoing. So if you all are interested in participating, please let us know. And finally, we have another B7H4 ADC, Puxi-Sam. This is Blue Star. This is the data that Linda Milchkin presented at ASCO. The objective response rate, again, at the higher dose, 47%. And Blue Star Endometrial 01, led by Stephanie Gayard, is also ongoing. So if you're interested in this trial, reach out to us.
All right. So we talked a little bit about Len-Pem after frontline. Rob, where do you fall on this spectrum?
Good question. So,
Thanks.
That's why I asked it.
yeah, I'm not. Yeah, I think the jury's still out on whether or not this is efficacious in that setting. I tend not to do it, to be honest with you.
So this is with previous IO.
Previous IO. That's what it says after frontline IO. just to be clear. I think that I think that I say the jury's still out because I think that there are nuances. The differential between progression on IO or versus prior exposure, and I think we'll get much smarter at evaluating biomarkers that will help us to identify who these people are. We're doing it already in other tumor types.
But what Brian said is anti-angiogenics are active as a single agent. So
exactly.
So
and we already have single agent data for lenvatinib as well in this disease.
Right.
So,
Right.
I mean, I tend not to do it, but I actually just did it on a patient.
So this is the confessional, but it's okay. You're still in
so
a
she
safe zone.
screen failed for an ADC trial, so I didn't want to use up my ADC option. So I'm like, let me put her on lenvatinib and see if I can rescreen her in a bit.
I think many of us have patients who did really well on this regimen before we were using IO in the front line. And so we've gotten used to managing the toxicity, though it's still a challenge even when you're good at managing it. So I think that's why folks have been slow to completely abandon that regimen.
Well, and we talked about this. If IO moved to the first line, that lenvatinib pembro would be very challenging. And I know there's an IIT out there with regards to looking at the post IO. We published small series about len-pem after IO. And there's efficacy.
There definitely are.
So I think from that standpoint, would I utilize it? Yes. Do I like to give len-pem? It's a really tough regimen, and it takes a lot of work. And a lot of side effects with your patient and working with them. Saying that, not after IO, but I have a couple patients who were cured of their disease. And so not after IO though, after, it's primary therapy, not previous non-IO exposed. So it is an efficacious regimen. We need data to really answer this question. I would love to do even a 100-person single arm trial.
All right. Katie, what do you think is going to happen when we start seeing the readouts from these TROP2 ADC second-line trials, and how's that going to change the landscape? And specifically, what's that going to do to the trials that are right behind them in terms of control arms? Are they going to need to change? What's the regulatory implication?
Well, of course, I think it depends on the magnitude of benefit from these positive studies. We've just seen press releases that they're positive, but we haven't seen the magnitude of benefit. And so certainly we're excited that not surprised that a topo 1 ADC that beats basically placebo, which is adriamycin. So that'd be hard not to do. So how much better is it, and really what's the toxicity? I think people have heard me say this. There's a lot of ADCs, and I think for me, if I have a number of ADCs in clinical practice, it's going to come down. I think the efficacy is probably going to be a wash, but maybe it'll be different. It's schedule and safety. So am I going to use something that's day 1, day 15 when I can use every 21 days? Nope. Am I going to use something that causes terrible mucositis versus pneumonitis versus I need GCSF? I mean, we're going to decide things in clinical practice based on the patient sitting in front of us and her wishes. From a clinical trial standpoint, I think it's going to do the same thing that we're seeing in ovary, where if it does get approved, it'll be first approved in the US, and then it'll be available therapy. And so the control arm, depending on how much better it is, will be considered potentially unethical, and it will complicate completion of phase 3 studies, at least in the United States, and they'll move to complete in Europe.
Outside
and then we'll
of the
have
US,
to, we're going to have to do cross-trial comparisons to sort of look and see what we think it is. It is a complicating factors of drug development. So,
just one comment. I think since the press release for SAC-TMT came out, I think the most important 3 words people are saying is, what does in certain populations mean? So we want to see what exactly they're going to mean by that. Is it going to be biomarker specific? Is it going to be in certain different patient populations based on TROP2 expression? So, but you're right. It's going to be magnitude of benefit and toxicity profile.
It's pretty common language, though, in all the press releases these days. It is. It's FDA.
But we've also seen a lot of press releases that we got excited about. And then we've been,
So 3095, as you know, enroll biomarker positive and biomarker negative patients. And as you also know, that carcinosarcomas have a differential expression of TROP2. So I don't know what they're referring to, but as you said, it'll be interesting to see the data.
Stay tuned.
Stay tuned. Hopefully sooner than later. Joyce, we're so grateful that you're with us, Dr. Barlin. And thank you from Albany, New York. Let's go ahead and talk about our second case. Go ahead and take it away.
Great. All right. Thanks for welcoming me to join you. And we'll talk about case 2. And 75-year-old presented with postmenopausal bleeding, general past medical history, hypertension, hyperlipidemia, diabetes, has some thickening on the endometrial biopsy, shows grade 3 endometrial carcinoma. The pathologist hedges a little bit, says maybe there's a serous component. I think a lot of us then do a workup, including CA-125 and a CAT scan. Her CA-125 was normal, her CAT scan was negative. She undergoes a robotic hysterectomy, BSO, sentinel nodes, omentum, and the final pathology shows a grade 3 endometrioid endometrial adenocarcinoma, 70% invasion, positive LVSI, lymph nodes are positive, and the omentum is positive for microscopic disease. Let's talk about tumor testing. So certainly we've all now incorporated that, and so she's pMMR, ER negative, PR negative, so that's how we're differing from our case 1. HER2 is 2+, and TP53 mutated. So these are the things that stand out a little bit from case 1. So we're going to bring this up twice, so we can just right off the bat think about what do you want to do with standard of care. So certainly clinical trial is the right answer, but if you're talking about standard of care options, then we can go.
Go to the next one.
Quite how we want the slide.
Go to the next one.
That's okay.
But this is a beautiful case. Thank you.
Pilot reel on a Friday night. It's a little biased.
So this is where it gets tough. And
Okay, so now you really
yeah.
have to put in some work. So you're going to do carbotaxol IO, you're going to add Bev, based on 86P, you're going to do IO plus Bev, you can do carbotaxol and trastuzumab, she's HER2 2+. So now we really want to know what you guys are doing, because I don't know what to do.
Mutated.
It's mutated, yeah.
Is she amplified HER2? She's 2+.
2+.
And
fish?
What's her
2+,
fish?
yeah.
We left it intentionally ambiguous.
Yeah.
Well, I mean, while they're answering, for trastuzumab, 2+, you need fish confirmation.
Yes, exactly.
Because you're working on the mechanism.
Correct.
For ADCs, you don't, because it's purely the anchor.
It's just the target.
So it's important to
We'll
have
say
that
fish
trastuzumab.
positive.
Mm-hmm.
Yeah.
So I don't think you can.
Yeah, right after you've already voted.
Revote.
Wait a minute. I'll change it back.
You can change your vote on this. I did it like 3 times.
So it actually looks like you did it 4 times.
Edit response.
And this is a real life scenario that we see commonly, right? So I appreciate you bringing that to us, Joyce.
All right, so
Obviously, you have the trastuzumab, the Amanda Nicholas Fader phase 2, and then the IO, the Ruby GY018. Let's go back a slide. I got it right here. Well, we lost our Slido, but and then obviously
here, I'll get you.
bevacizumab quadruplet, which is interesting.
It was.
And then ultimately, maybe because P53, and you'll give IO later. Pemlen.
that's true. Lots of options. But let's talk about, all right, we'll get past our Slido
It's
and back up a couple slides. I'm not sure how we got here. Can we?
and back up.
You go back. There you go. One more.
Keep going back. There we go. All right. So now the real answer, as 100% of you said, was clinical trials. So let's talk about what clinical trials you can open at your institutions. So we have NRG GY035, our phase 3 trial run by Amanda Nichols Fader, and this is carboplatin paclitaxel pembrolizumab versus carbotax bev versus carbotax bev and pembro in pMMR TP53 mutated. So one thing to keep in mind as an option. You get a little bit fancier, and so this is being run by Dr. Moore. This is symbiotic GON18, GOG 3145. So this is a phase 3 randomized open label study in advanced or recurrent endometrial patients with proficient MMR status. And the study drug is an investigational tetravalent bispecific antibody that simultaneously targets PD-1 and VEGF. Randomized 1-to-1, carbotaxol and pembro with pembro maintenance as your control arm versus carbotaxol study drug with study drug maintenance. You can also think about Destiny Endometrial 01. This is run by Dr. Macker with a co-PI of Dr. Geller as a phase 3 of trastuzumab deruxtecan plus, what's your shortened version of this one?
Rilvi.
Rilvi, right. Or pembro as first-line treatment of HER2 expressing 2+ or 3+, mismatch repair proficient endometrial cancer. So your control arm is carboplatin paclitaxel with your pembro. Now this is trying to replace chemotherapy. So this is TDXD plus pembro or TDXD plus Rilvi. So very interesting population to think about for clinical trials. Another option would be Trofuse 033 or GOG 3119, run by Dr. Monk, as a phase 3 study to compare sacituzumab trutecan in combination with Pembro versus Pembro alone. So now this is a maintenance trial. So you get your carbotaxol Pembro, and then you would get randomized to Pembro maintenance alone or study drug with plus Pembro maintenance. So just as a bit of a background in terms of what your clinical trial option landscape looks like. And so now it's a matter of which clinical trial, and we'll let Dr. Monk kind of guide our.
Hold on here. I want Dave to give it to us again. So Dave, you got treatment versus maintenance, biomarker versus non-biomarker, ADC versus non-ADC, energy versus GOG partners. Should you open more than one trial in this space?
I think that probably makes sense.
That might make sense, yes.
You might need 2 or 3.
Thank you, Leslie. This is the point, is this basically gives you so many different options. And then, so now here you go. Go ahead, Joyce. I just love how that menu, that palette, the colors, you got every color on the color wheel.
Yeah, so I think it's not within Slido, but maybe we could just talk about across the panel how you would decide which trial to prioritize, what patient population, and how you make this decision in terms of what trials to open at your institution.
Go ahead, Brian.
Yeah, so I love all 4 of these trials. I'll tell you, I'll favor the others. The first 2 I love because they're non-ADC. And there's 2 things we have to consider. One, just because ADCs work in the second line, carboplatin paclitaxel is tougher to beat in the first line. We learned that lesson with LEAP, right? 775 was positive, but was negative in the first line. So maybe it's not going to be an ADC in the first line. Or we also have Destiny-02, which is TDXD in the adjuvant setting. Maybe they would have already gone to ADC. So I like the 2 non-ADC trials. I like Destiny-01 because it's treatment. It's getting rid of chemotherapy potentially. Okay, which is an exciting option. Again, if we could get rid of carboplatin paclitaxel in the first line, or maybe we'll get rid of it totally, that's a great option. I think if that's a positive trial, it's really going to be a great option for our patients. And to the finally, I love the 3119 Trofuse 33 trial because everyone's getting the standard of care. So everyone gets a proven treatment, and then we want to see if it's different than maintenance. So there's a lot, to Dave's point, there's a value of opening maybe more than one of those trials in your institution because they're not all the same.
Yeah, I think if you're strongly committed to wanting to change that taxane platinum backbone, you're going to go down that trial that's actually looking at the treatment change. And you're making that decision at the beginning. The other, if you're hesitant, then you're going to say, okay, let me see how these patients are responding to standard of care, and then I'll make that decision later. See, it's not made at the same time. And so I think you have to be thinking about whether or not this patient's a good candidate for a maintenance strategy or for a treatment.
But the other point, Katie said very nicely that in the PMMR setting, it is a standard of care, not the standard of care. So basically these trials try to take that and make it better, either to replace it with chemotherapy or up the ante. And then it's, Bev works in endometrial cancer, so I like anti-VEGF because one of these is a bispecific. I like the 2 shots on goal for anti-angiogenics.
Yeah. And I like that trial because it includes both. It doesn't just include P53 wild type.
There you go.
Abnormal.
As opposed to the energy trial that does.
Exactly, because I think there's you have the beta-catenins in the P53 wild type subgroup that do worse. So I'm glad that they're being included.
But then, again, the hypothesis for 35 is that the P53 wild type or mutated tumors are following along those subgroup analyses. Right, we got from 86P and from the Ruby that those mutated population may actually be the best candidates for their respective agents. So again, it's testing the hypothesis.
Yeah, but 86P also showed that the beta-catenin patients did better with bevacizumab in their subgroup.
Let's just be careful about 86P. It was a single arm. They weren't comparative trials.
There was no control arm. I understand,
Right.
but I'm saying
Bev and temsirolimus and
the point is not that the regimen; it's that it was based on a hypothesis that was generated from that subgroup. And again, testing the hypothesis. Yes.
But to that point, you can select based on biomarker. If you have a 1+ versus a 3+, it's probably going to make a difference in what I recommend. Obviously, the P53. So to that point, to reemphasize, 2 to 3 in that setting
Yes.
is very doable.
Exactly. Yes,
And you offer, I've always said, everybody in our practice, I want that patient to have 2 options. I want that practitioner to have 2 options, knowing that one of those 2, they should be able to find a fit for the patient.
Exactly.
I like what you do here, Joyce. You just crossed out the PMR because now it's DM. So just
like
kidding.
we're taking boards.
Just kidding.
Exactly, yeah, exactly.
Go ahead, talk us through this now. Go ahead.
All right, so let's make it more interesting because I think that endometrial cancer it's a very exciting time, but it remains clear as mud as far as I'm concerned. So it's nice to have a panel of experts to agree to disagree. So let's change the scenario to DMMR patients. So the patient gets paclitaxel, carboplatin, and pembrolizumab, gets pembrolizumab maintenance, and then progresses 10 months after starting your pembro maintenance with mediastinal and retroperitoneal lymph nodes, so not a surgical candidate. Tumor testing, so now is considered DMMR, still ERPR negative, HER2 2+, FISH positive, TP53 mutated. And so what do we recommend for treatment? At this point, we'll see kind of what the audience offers. So you can do paclitaxel, carboplatin plus Bev. Oh, don't see that.
Go to the next question.
I would biopsy to make sure the nodes are real.
I don't see that very often.
Can we go back one?
Very unusual. Yeah.
So like I asked you before, Rachel, is it unusual with the LGSOC recurring quickly? This obviously is a little unusual, but how do you look at this sort of DMMR IO exposed opportunity moving forward?
Yeah, well, it's I think we always think that those MMR deficient patients are going to respond to IO forever, and in real life they don't. But I'm really grateful that this patient is HER2 2+, because I know I've got a great standard of care option there. So of course I'm going to be looking at what clinical trials I have, but I would consider that to be my standard of care second line therapy here.
I would agree with that. I think anyone who's done it cannot argue that answer at all,
again,
because you see it work.
And we were talking earlier today about, I think we all have these patients where we've been amazed by their complete and lasting responses to TDXD in this setting. Something that we don't see with so many other therapies. And so it's just really appealing.
And gives us really hope for curative intent in that first line with the addition of the ADCs.
Yeah.
And it makes me more excited about ADCs that are topo, that are less restricted than the biomarker driven.
Yep.
So
I think, was there a comment?
If she got Pembro, she got Pembro. She didn't get her Herceptin up front, but she's 2+.
Yeah, if she would have got trastuzumab up front, would that have changed your opinion, Rachel?
So that's actually the reason that I've kind of shied away from using trastuzumab up front now. So I used to do that when I didn't have TDXD in the recurrent setting. Now I favor chemo IO more in the upfront setting. And I know I usually say use your best drugs first and don't save it, but I don't want to do anything that could potentially decrease my activity of TDXD in the recurrent setting. So I would say I favor chemo IO in that population more than I used to.
Yeah, go ahead.
The Fader data is so strong. I mean, why wouldn't you use Herceptin issues?
Because she was DMMR. We flipped it to DMMR. So now that it's DMMR, we think the decision was simpler, and yeah, that's a good point. But it's true, and there is evidence, obviously, that TDXD works after trastuzumab, although right?
At least in breast.
Yeah, and then even just to complicate the matter a little bit further, so I think we already touched on, IO after IO, a little uncertain in terms of do we do lenvatinib addition to pembrolizumab. And so there is, some data to look at, and this is courtesy of Dr. Eskander. So in terms of the time to post-progression IO therapy in the PMMR cohort, so there were 48 patients in the pembro arm that then received lenvatinib and pembrolizumab. There were 136 patients in the placebo plus chemo arm that received lenvatinib and pembrolizumab. And then the median time on treatment was similar, so 6 months versus 5.5 months. So I guess the other thing to keep in mind is that the FDA approval and the NCCN listing for lenvatinib pembrolizumab is restricted to PMMR and not DMMR.
That's correct. Ding, ding. This is obviously a very interesting, exploratory, ad hoc analysis.
Right.
And obviously it's duration of treatment rather than sort of radiologic progression. I think what we already said is it needs to be tested, Dave, right? And it could easily be tested in 100 patients.
So the take-home message is that we have to keep asking questions. It's the Socratic method at work. If you invite me to participate, this is what you get as my slide.
All right. I love it.
Excellent.
Dr. Barlin, thank you. That was wonderful. Appreciate it. All right. Yeah. Just give her a round of applause. Thank you.
But the ovary session was better, right?
Nah.
Did you get a
Get the Slido back up. All right. So any questions from the audience? And any last thoughts on endometrial cancer before we move on to cervix?
Yeah, go ahead.
Scott?
What do we do with the results of GY026? I love it. I have it open, but if it's a positive trial, how do we factor that in?
Yeah.
How do we factor that into chemo IO and then potentially DE01?
I think it's going to depend on, again, it's going to depend on the magnitude of the results. The 026, I love 026. The part I love most about 026 is the early stage inclusion, because Britt's presented this, Dr. Erickson, sorry, and it's all retrospective, but these HER2 2+-ish, 3+ stage 1, stage 2 serous tumors look like they do markedly worse than their HER2 wild-type counterparts. And so if we prove that we can cure more of them, which we might do, then that dramatically changes the standard of care, in that setting. And that's where we detect most of them, right, is stage 1, stage 2. So I think it's an incredibly important study to finish. And my second point about it is that, I love ADCs. I think everyone in here knows this. I love ADCs. But I have a little tension about them in the front line. I'm running a study in ovary, so I'm talking out of both sides of my face right now. But if I can cure people with 3+ with trastuzumab, without pneumonitis, without bone marrow damage, if I cure them, then I would much rather use that than an ADC. If it looks about the same, or the other ones, like we're going to be Rob's going to be overlaying the curves for us and doing all the things, then I'm not going to use it. So I think it remains to be seen. It's a really good question. I definitely was on a stage once. I'm like, why are we using a drug that's a quarter century old? I've said that, and I take it back. I don't think I'm right. I think it's a really important study for us to finish.
It is.
All right, Brian,
I know we're
close us out on endometrial.
I know we're finishing up this session, so IO for all patients with endometrial cancer, likely ADC at some point. There's a desperate need, and go home and think about it, a desperate need for post-IO, post-ADC clinical trials. Right now we have 2. We're looking at a CHEK1/2 manipulator in uterine serous cancer patients. That's open and accruing. The sponsor there is Acrivon. And there's a PICTOR with Taxol, going back to this mTOR PIK3CA maintenance trial that we have open with one of our other sponsors. And we have in our IIT group, actually, I don't want to forget Stephanie Agaird's leading a PIK3CA alpelisib with letrozole trial as well. So we need, as these patients are becoming more and more durable, as they need more lines of therapy, we desperately need to get data because I don't think IO after IO is going to work. I don't think payload after payload is going to work. So
good summary, Brian. Appreciate you. Let's now transition to cervical cancer.
All right.
Dr. Leslie Randall.
Let's go. Best for last.
Go ahead.
That's right.
The best session
Let's go.
Keeps getting better.
Keeps getting better. So not as much new data or trials in cervix, but I think we're all still trying to decide how we apply the data that has come out recently. So let's go through cases. We're Slidoing. This is quiz show. So 38-year-old with abnormal uterine bleeding, pelvic pain, last PAP 4 years ago with their last pregnancy. You see this every day. 6-centimeter exophytic cervical mass with parametrial extension all the way to the sidewall on the left. And a punch biopsy shows adenosquamous histology, carcinoma. So your imaging, PET CT confirms your exam. You see an additional hydronephrosis on that left side with 3 pelvic nodes and 1 periaortic node. At L3, they're SUV greater than 9, so suspicious for metastatic disease and no distant disease.
Okay, so you got locally advanced cervical cancer here. Yep. So what are you going to do for this patient? Are you going to put her on a clinical trial? Boy, people are so fast. Are you going to do cisplatin, external beam radiotherapy, and brachytherapy? Are you going to do induction cisplatin, EBRT brachy? therapy, or you can do cis EBRT brachytherapy.
I got this one.
And you have a Pembro choice in there too. Sorry, I was jumping around.
Yeah, 18.
Looks good. I have a slide for all of you guys, but yeah, looks good. Yeah.
18
So I think
versus
the important thing here is the staging. So, you know, I've heard a lot of talk about folks getting PD-L1s at the locally advanced disease stage and deciding whether to give pembrolizumab, the 18 regimen based on PD-L1. It's really stage-based. So here you had disease out to the sidewall with the hydro. You know, it's something that will make everyone's life really easy is if you start cervix cancer, thinking of it as in the TNM stage, which sounds a little crazy, but it's actually a lot easier than trying to go back and forth between the different phago systems. But I think, yeah, these are the different options. Okay, so we're going to go to case 2. And case 2 is going to be a little bit similar, and I want you guys to remember these cases because we're going to follow these patients out through their subsequent lines of treatment. So this is a 62-year-old patient with a remote history of CIN3 who has a 4-centimeter mass, less than 1/3 to the sidewall, and a squamous cell carcinoma. PET CT confirms the exam again with 1 pelvic node, SUV of 4.3. So this is less advanced disease. So what's your treatment choice here? So here you have the same options, but just a different patient. And again, we mentioned that the PD-L1 here, you know, this is not important information at this stage of the treatment paradigm. All right.
You know, I get the sense, Leslie, and thank you so much for your editorial in, I think it was Lancet that you wrote, maybe Lancet Oncology. What was it, Lancet?
Linda Deska, who just left.
Was it Lancet or Lancet Oncology? For
Lancet Oncology.
So that was interesting. I get the sense there's a lot of skepticism in the U.S. about interlace. Do you feel that, or you know, I don't know.
I think so. I think it's fair.
It was a good editorial, actually.
I
There's a lot of focus
that.
on the.
We thought about it. It was
a lot of focus on the radiation techniques and such that were included.
But where does the skepticism come from?
That.
Well, I think a couple of things. I mean, first of all, it took a very long time to complete, and so there was quite a bit of change and radiation effect over time. It was a lower risk population overall, though higher risk patients were eligible. I think there's a bias that chemo-RT alone can really cure a lot of these patients, and I think that that's very true. So I think that now that our radiation therapy techniques have evolved so much, that maybe you don't need to escalate treatment in patients who are likely to be cured with chemo-RT. And I know if there are any radiation oncologists in the audience, they would probably very much agree with that because that's who, really challenges me to focus on those patients who are likely to be cured with chemo-RT alone.
So down to my left, so where Pembro is in the life cycle, you can, I don't know if you can, but I think I get the sense that you might. It sort of gets paid for anyways, even though it's not on label. Neither one of these patients were out to the sidewall, bladder, rectal, or ureteral involvement. Are you using it? I hate to use the word off-label because that implies that you're doing something wrong. Are you doing it according to the clinical trial of 18? That's a more positive way to say it. And I want to hear from you. Yeah, go ahead.
The first patient had hydro, so she definitely.
Oh, right. So she had hydro.
So she
got
it. This patient does not, so I would not be using it here.
But she had positive node.
Yeah, 1.
Yeah,
and it wasn't. Yeah, it was negative. Yeah, it's a reminder.
Okay.
I'm using it on the label. I think a 35% IO toxicity rate, and again, this is every solid tumor shows 35% plus or minus 5%. 5 no more than 10% with regards to severe. But the benefit here is unclear in this group of patients without sidewall disease. I think some of the concern with regards to interlace, if you're going to do it right. Perfect segue, GY037, right?
Go ahead, Leslie.
So the right part is immediately to chemo-RT and not to have a delay. And the intent of induction chemotherapy is not to bridge a gap to chemo-RT. That is not how the trial is designed. Can't interpret it as if there's a gap, but that probably wouldn't have produced the same results. So I think in the A18 label population, we have the GY 037. You know, what do you do with that non-label population? They were eligible for the trial. The forest plot showed the magnitude of benefit was less, but there are plenty of people who rationalize that if they were included, it was overall positive trial, and no positive patient, even with the smaller tumor, is a high-risk patient, and you want to escalate their treatment in some way, and that's one way to do that. Now, this study won't answer the question of the smaller tumor node positive patients. This will be limited to the on-label population, the T3, T4 tumors, with or without positive nodes. So this is basically A18 with or without interlace. Exactly.
And that's what I meant by do it right. Use your best regimens. If you're going to give chemo and cause alopecia, if you're going to give chemo and have a risk of IO toxicity, a little bit different scenario, obviously, then, to me, use your best regimen.
Yeah, agreed. Go ahead, Leslie.
Yeah.
All right. Keep going here.
There you go.
So, the IO induction, we did this in GY 017, I think Dr. Mayadev's trial. So Colibri was actually presented at ESMO GYN. This has been presented before at ASCO a couple years ago. This is the Geneco group in France. They are giving a dose in this protocol. This is locally advanced, and this is inclusive of the entire A18 or the entire interlace population. So these are either smaller or larger tumors. They're giving a dose of ipilimumab and then 3 doses of nivolumab as induction. And this is really interesting because the main endpoint of the study is mostly translational. So they're looking at several different immune markers. And what I think is really interesting, and this is a great presentation, I don't have time to show it all here, but what they have been able to show in this population is you can convert a cold tumor into a hot tumor, and not only make it potentially more susceptible to immunotherapy, but also more susceptible to the chemoradiotherapy that you're about to give. And you can see, there's no control group here and there's no comparison, but there's some, very good outcomes compared to historical controls in these groups, especially those patients whom you could convert from cold to hot. So this is really interesting, and I think the immunotherapy story is not over in locally advanced cervical cancer, and I took out the EVOLVE study slide because it's not open here in the US, but that's PD-1, CTLA-4 in a maintenance setting. So still working on this. So now we've given these patients treatment in a locally advanced setting, and you got to really, you got to stay awake here, guys. I know it's late. But you really got to think. This is like the mom slide where you're doing like 10 things at once. So, or the dad slide, or any multitasker. For case 1, so we remember this is our patient who was IO treated. We're looking
3B.
3B, exactly. So this patient's been disease-free for a year after completion of that pembrolizumab maintenance. Recurs in the lung and a left supraclavicular node. The lung biopsy confirms it's the same adenosquamous cancer, and the biomarkers are here: PD-L1 positive, but with a CPS of 5%, HER2 2+, and PIK3CA mutated. Now, the case 2 was the earlier stage patient, most likely treated with chemo-RT, plus or minus interlace, disease-free for 3 years after completion of cis-RT, recurrent in the sigmoid colon and liver biopsy confirmed squamous cell. Now, the biomarkers on this tumor are CPS of 50%, HER2 0, and a P53 mutation. All right, so what are we going to do for case 1? So IO treated, CPS 5. What's our preferred treatment option? Is it the GOG 240 regimen, cis-taxol-bev? Is it the Keynote 826 regimen? Is it BCC, bev, atezolizumab, 826 without bev, or trastuzumab deruxtecan? I want to vote. I want to know what you all are doing. I think this is a challenge. We don't know. We're not sure what to do with these patients, right?
So did not progress on Pembro. Did not
progress on Pembro. I'm not sure it matters, but did not progress.
A year later. Oh, it matters.
Yes.
Yeah, so you've got a treatment-free
Dave, you just affected the answers.
I know, right? Totally. Contamination.
No, I
Voting
was
contamination. Trump was right. Voting contamination.
Yeah, there's your bias right there.
Yeah, things nobody's ever said.
Wow.
Look at that.
This is incredible.
Isn't that cool? Yeah.
Yeah.
An IO exposed patient.
And an IO exposed patient.
Yeah.
I did not expect it to be this this clear cut. Maybe I'm the only one that's confused.
What happened to our clinical trial people? Now they're down to 10% for clinical trial.
That's great. Any thoughts from?
We forgot. Good thing they didn't say clinical trial because there are none.
Right.
Yeah.
There you go. There's
none.
Another gap.
There's no clinical trial.
I mean,
What do you guys think about that? So non-progressive on an IO. but now
IO
we're-
after IO is untested.
Exactly.
Right.
And that's why, personally, I would do 240. But just
what I
as a
would do.
conservative,
that was-
conservative.
Yeah.
Yeah,
I'm
she had a
jump-
break. I'd
I
probably
know
do
she
B.
had a break.
I'd probably do 856.
It's like
Or
PARP
26.
after
I'd probably
PARP.
do
826?
with cis.
Yeah, I'm probably going to give the patient the benefit of the doubt
Fair enough.
What's the benefit of the doubt?
that Pembro might help her.
Yeah, if you want to,
because
In the
you've got
previous
one
IO
shot,
exposed?
you've got one more shot at this.
She
to
didn't
control
progress on it.
disease. Yep.
if you want to
So-
borrow from some unrelated data, when you looked at SAC-TMT in cervix cancer
Yeah.
versus the numbers, not cross-trial comparison, versus SAC-TMT response rate with Pembro, it was 57% SAC-TMT and Pembro in a group of patients that had pretreated with
Yeah,
Pembro.
you're jumping the shark because we're going to
Good
get to
point.
that. But that's okay. That's okay. Yeah, I agree with that. I think that we've got in TV as well, right? TV plus Pembro. So we've got some data to show that even in, well, TV plus Pembro was not with IO.
I heard a scream from TV and Pembro over there.
Yeah.
I like it.
Oh,
I don't
okay.
think 240 is wrong though. I don't disagree with you.
That would be.
I don't
That
I don't disagree with
But
you.
based on the
and-
data we have, I agree.
Yeah.
Well,
I think
Brad
there's a-
said it,
I think
so I
there's a-
think it was wrong.
Yeah, I think there's. I think there's several good options here, right?
Yeah.
Yeah,
I think,
exactly.
You know, and I like how we've stacked the studies supporting each of those behind them.
So let's go to the IO unexposed patient here. So what regimen are you using here? I think if you're,
I think we
we
have
already know the
Slido.
answer.
Let's go to
this.
Slido.
Yeah.
Yeah. Let's go to the Slido.
It's gonna be the same.
Clinical trial.
I think it gets easier in the IO non-exposed patient, obviously.
I'll be Dave O'Malley. I'll affect your
PD-L1
result. Why not a clinical
positive.
trial here?
I should have made it a point. Well, that's
that
right.
is.
This is the one that was.
Okay.
I'm going to edit my
See?
response.
Instead of play a Dave
You're
O'Malley.
coming.
There you go.
We're coming.
And Leslie,
My response.
Negatively.
There we go. Come on.
Oh, now it's good.
Leslie, just to remind them, this is the one that had PD-L1 CPS 50.
This is 50%.
And HER2
CPS
0 and
I-
P53
Yeah,
mutation.
IO naive,
And IO
CPS
naive.
50.
And liver
That's
biopsy was squamous cell recurrence.
That's
Free
right.
beer if
Same
you put clinical
pathology.
trial.
But I think it's interesting that it's been almost 100% clinical trial. There is a clinical trial, which we're going to hear about in a minute, that this patient, at least in my opinion, would be an ideal candidate
Yeah.
for. So I think that's part of the education why we're here now, is to learn about that clinical trial, which is very new. It's okay.
And
And
there
the
it
sites
is.
are still opening. So go ahead.
Great. So I should this is, Dr. Slomovitz is leading this trial globally for us. So this is an IO naive PD-L1 positive population. This is an 826 replacement. So patients get the 826 regimen. And after 6 cycles of induction chemotherapy, they randomize to continue on their Pembro plus or minus Bev as maintenance with or without SAC-TMT. And not shown on this slide, there's an arm where patients progress on chemotherapy induction phase. They can go onto the SAC-TMT Pembro combination arm, which I think will be a really interesting arm to see in the front line as well as we see ADC, IO move into the front line and other tumor types. So I'm excited to have some opportunity to get that data for our cervical cancer patients.
Agreed.
Yeah.
I mean,
So-
we should put 100% patients.
Can we revote?
This one's yeah.
Yeah, I mean, this is to me.
This is like this is an easy decision process because they're getting good standard of care in the control arm.
And we're not curing very many of these patients, right? This is not a disease where we're going to cure them.
Whoa,
anyway.
whoa.
Yeah, we've
Whoa,
made a huge
whoa,
impact.
whoa.
Right?
How many? What? Of metastatic?
Let me teach
Not
you.
the majority.
Metastatic peritoneal disease.
Let me teach you.
Oh, I can't wait for this.
Now pay attention.
In the 5-year data, just listen, you guys. I know it's late. In the 5-year data from Keynote 826, at 5 years, 30% of the patients are still alive. Okay, so a third of them.
Still alive.
Still alive.
With disease, without disease.
And most of them are progression free.
Okay, how many of those had peritoneal disease?
So the next
0.
No, it's not true.
That's true. 100%.
The next thing is the leverage of the PD-L1 expression. If the CPS is greater than 10, that increases by 50% more. So to Tom's point, it's easy to be pessimistic. Oncologists are inherently optimistic. So let's give them a chance. And so I just don't want to try to endorse pessimism.
I'm giving you a lot of grief on this. I agree we can cure these patients. This particular one with peritoneal disease, that was the reference.
It is, and I also admit that peritoneal metastases in cervical cancer is a poor prognostic, as is liver metastases. That's right. Thank you for that. All right, keep going.
I think I was changing the face of that editorialized, but you guys are making a great argument for why this trial needs to be done.
There you go.
Right.
There you
That's
go.
my whole point.
There you go. Let's go.
Because I mean, we have really made a huge improvement, huge impact with Pembro plus or minus Bev. And if you can give Bev, you should, because it based on the median overall survival times, it adds an entire year to the median OS times. But do we need more? Are we done? Like, is that enough? Or do we need more? And this trial will help us answer that question.
Yeah, I think, this is a great legacy of the NRG GOG process. When we started with platinum 40 years ago, 30 years ago, we were looking at median overall survivals of 7 to 8 months.
That's right.
And now we're in the 30 plus months. We've quadrupled overall survival. We've done this iteratively, and we've done it because we did a ton of these types of trials trying to sort out what was the best. We added, we changed the backbone to the taxanes, we added bevacizumab, we added IO. This is a real success story.
Thank you.
I mean, we got excited with Taxol from 7 months to 9 months.
Yeah, I know that. We were like
while I've
celebrating.
been at Ohio State.
Yeah.
I've been there a lot.
And now look where we are. So this process, it works.
Absolutely. All right. Well, 50 sites will be open in the U.S. So if you don't have, either open it, get it open at your site if you're in the process, or find the site closest to you. Oops. This is a little touchy.
Yeah, just to highlight, you have to sign them up before you start chemotherapy.
Correct.
So even though it's a maintenance trial, it's super important to get them, if you're going to refer them to a local center that has it, or even if you have it in your center, don't just start chemo thinking in your head it's a maintenance therapy.
So don't wait until you have a patient to find your site. Find your site now.
It's the same for
So you're ready to go.
3119, and right. So because they want the biomarker for stratification, and also the Pembro's provided. So that's another important reason in both studies.
Yep.
Great points. Okay, we're still multitasking, so keep your patients straight. So case 1, this patient is progressing on Bev maintenance, 8 months post-platinum. CPS, again, this is just reiterating the biomarker, CPS 5, HER2 2+. And case 2, you're progressing on pembrolizumab and Bev maintenance, 18 months post-platinum. CPS still 50%, HER2 0, and P53 mutated. So for case 1, what's your recommended next line of treatment?
And what's her HER2 status again? It's 2+.
It's 2+, and she's the one that progressed on Bev. So you're going to do trastuzumab,
Case 2 is,
deruxtecan,
It's an
you're going to do clinical
adenosquamous.
trial, you're going to do
HER2
tisotumab
2+.
vedotin, you're going to do tisotumab vedotin plus Pembro, or you're going to do pemetrexed, or a clinical trial.
Right. Makes sense.
Right. I think it makes sense too.
Yeah.
You're not going to find these very often
like
in
it.
cervix, right? HER2. More common in the potentially adenosquamous. Kind of made it that way.
So we have 75% people taking how many? We had 11 patients in the 2+, versus phase 3 overall survival advantage.
That's a great point.
Really?
Great point, Dave. Great point.
Well, I mean, those are pretty important 11 patients. Those are as important as the 11 with no myometrial, no residual disease in our serous
2 months of OS. 301. 2 months of OS.
But remember, there's different payloads, so you can give both.
Meetings don't count.
Yeah.
So what's the drop-off rate in cervix cancer? Speaking of
It's
Oh, it's
high.
very high.
We're going to look at it.
40% from on
Yeah.
TV. I think Leslie's going to show this. It's 40%. But if
Yes.
you give TDXD, and I think it is 11 patients, you're right. But I think we've had enough treatment in the wild for these patients with 1+ even that we have a sense of how well it's working. And the likelihood of getting a response here, I think, with TDXD is much higher than TB. So I think I'm going to use TDXD first, and then she's going to feel better. And then when I see a little bit of progression, I'm going to put her on TV. If I put her on TV and it doesn't work, then she may not make it to TDXD.
I agree.
But I think you're right. I mean, the level of evidence is much higher for TB, but that was before we had any of these medicines. And so we're applying an OS standard that doesn't really, that control arm doesn't apply in this setting anymore.
Well,
And the bar was low.
It's 17%.
The bar was
response
low.
rate is very
Right.
wide.
Yeah.
TDXD is
Yeah.
still only approved for 3+. There's only
Exactly.
NCCN guidelines, not approved. So I think, again, do I think that's wrong? No, but I think we can't dismiss phase 3 data for a small single-arm 11-patient phase 2. Not that, I know. And again, we use this. I think it's a reasonable option.
So TV Pembro was in here. I'll go to the moderator, Brad. This patient had a break between Pembro, a Bev regimen,
I know,
and
that's a
then,
good point.
and then back to this. So, what would you expect?
I don't know. It's easy to be professorial and confident, but I think the Pembro break, I think probably has some leverage. I don't know how much. I don't know.
It was in lung cancer. I mean, they had a 6-month window is the kind of the.
I don't know. It is NCCN recommended based on trial that you did. So good point.
All right. So case 2, basically the same options here. So this is your HER2 0 CPS 50%, and now I've even lost track, and I've gone over this case 100 times. So if you
She had, so we're assuming she had the.
She had
Case 2 had progression on
She had
Pembro
826.
maintenance.
Pembro maintenance. Thank you.
Yes.
HER2 0,
HER2 0,
mutant, PD-L1.
P53 mutated,
Yes,
yeah.
There you go.
It makes it easier because it's progression on Pembro.
Right.
Yeah.
It also makes it easier because she's the more typical scenario, HER2 0. So that's why the answer is the answer that you see, and obviously a clinical trial is a good answer. Now, clinical trials in this space are very rare. They're not non-existent, but they're pretty
They need to be
rare.
less rare.
They need to be
for all
less rare.
sponsors in
They
the
need to be well
audience.
done.
Yeah,
Yes.
that's right. They need to be less rare. We need more to talk about.
So usually on this patient, I'm going to start with TV. And those, sometimes you get a response, and then after some time, like you could see you're starting to get a little bit of mixed response. Those patients I add on Pembro, or I add on Carbo to the TV, and you sort of supercharge it a little bit to get some more time.
So thank you for that. Carbo TV is a well-reported, published, more than a 50% response rate, but that's in the first line.
Yeah,
That's right.
But again, you have to be creative here. So
You
I
have to
think
be
that
creative.
yeah.
And I've totally
all
done
do.
it
It's
too.
the
get
art of
platinum
medicine.
resistant
It's the art of
versus
And
medicine. It's the art of care.
radiation of oligometastatic disease cannot be underestimated.
Absolutely.
But I was surprised by the 9% who picked TDXD with HER2 0.
This is the one standing by the bar.
Well, I mean, if you take the breast cancer literature,
ultra lows.
if you have any little brown in there whatsoever,
right.
in the ultra
But
lows.
over tisotumab vedotin.
There you go.
No, I didn't do that.
All right,
I
Leslie,
don't think I did that.
wrap
We're
it
going
up
to keep
here.
going.
Yeah, this was
Yeah.
really good.
So this is the current ADC status and second line plus. So these are your FDA approved or NCCN listed options. You guys are using these. You've shown that in your responses. Investigational agents have shown some even higher response rates, SASI-GOVI, SAC-TMT alone, and SAC-TMT with Pembro, as you alluded to earlier, Brian. So, the SAC-TMT Pembro combination with the 50% response rate in a median not reached, and it was 60% in the IO pretreated population. So I think that these IO combinations are a real signal in recurrent cervical cancer. So all night long, we've been talking about IO or endometrial. IO after IO is probably not going to be effective, but I think cervix is going to be different. And it makes sense, right? Because of how the biology of cervical cancer and how effective immunotherapy has been in this space. No,
I don't know that I agree with that. All that data's from China.
Challenge me.
All that data's from China.
US-like population.
Not
almost.
The
TV205 is
the combination data with the TROP2s is almost all from China, which isn't saying, I'm not saying they're lying. I'm not saying that, but they're just entirely different
populations.
people.
Yep.
And so when we bring those things to the US and we redo them, we do not typically see that same things. I mean, if you want to do things, people do things in the wild all the time. They make things up and they do things because they're trying to do best for their patients. I'm not judging that. But I think we have to just be clear on what we're recommending. I don't know that I would recommend this as something that's working based on a cohort from China. I think we have to be really careful with that.
I think the CTLA-4 IO combination, even in IO exposed, makes perhaps even more sense than pembrolizumab in endometrial cancer in IO exposed.
Oh yeah, I think there's some.
Right?
That would be supported.
So that is. So I think we can probably talk about that a little more.
I agree with you, Katie. I think we need more data. I think we need to continue, but we can't. I think that if we're developing ADCs in the second line space, maybe we should be doing trials that are plus or minus IO to answer the question, to see if the combination works better in that setting.
And the nuances that you all brought up are things that we haven't really seen enough patients around yet, like patients that progress on Pembro, patients that progress after Pembro. These approvals just happened. So how often are we going to see a patient? Usually in a local regionally advanced setting, patients recur within that first 3 years. Like if you make it 3 years, there's modeling that says you're basically cured. So if we just push that out with IO and we're going to see these post-IO recurrences where this IO after IO question may be an entirely different one, but we don't even know what that rate is.
Correct. We don't know what that rate is, yeah.
Very much so. So here we have 2 new targets that have been recently presented. So we've got B7H3 and Nectin-4, and you've got different payloads here, as you can see. And you've got reasonable response rates here, definitely. I mean, the phase 3 TV was 17. So, we're increasing the response rates here. And durations of response, maybe not as long with the microtubule inhibitors, but longer with the TOP1s, but this is immature data. So, interestingly, one of these Nectin-4s, the Corbus asset, I'm not showing these data, but they actually found a pretty significantly high rate of ocular toxicity.
Much higher than that.
Yeah, much higher than what was seen in TV. And you have to wonder if they were thinking about the mitigation, the prevention strategy. It wasn't clearly discussed. So, here we have a phase 4 ongoing that's led by Scott Jordan, who's here in the front. And this is to confirm the ocular safety of tisotumab vedotin. And I think, I know that this was certainly a concern when we were launching this drug. And I know that some have long-term concerns about ocular toxicity. This study includes a 90-day treatment monthly, 3 additional exams for patients who've stopped the tisotumab vedotin. So this satisfies an FDA post-marketing requirement, but I think this is all important data that we're interested in. So this is going really well, and if you have a site close to you, I know it can be difficult for patients to travel for standard of care therapy, but if it's not very far away from you, you may want to refer them just so we could get this completed. That would be excellent. Great. So here is, it's a little bit of older data, but I think it's just really important to not forget that, especially in cervical cancer patients really fall off the treatment paradigm. So as we're developing more and more options, making them more tolerable, Katie, I love your point about, I'm going to give her TDXD, she's going to feel better, and then she's going to be more able to go on subsequent therapy to keep these patients on therapy, because I think there's a bias, especially for cervical cancer patients, not to give them subsequent therapy and to go, pretty quickly to hospice care. I mean, I had a patient on the podium at SGO, which many of you remember. That patient had a malignant bowel obstruction, had peritoneal carcinomatosis, like you all talked about, and actually got TV Pembro when it was first available, and is still around. So
I think it's a really good point. And, I think as we look at this, being able to offer our patients these options, hopefully with better options in all of our disease sites, we're not going to see as much drop off because people are getting response. They're feeling better. And with disease regression, you just see them having more resiliency to move into that next treatment. But I think we're really doing a harm to our patients if we're not offering them TV in the recurrent setting. I mean, it can be well tolerated. You can get very nice responses.
Yep. You got a comment, Rob?
No.
Okay.
All right. Thank you, Leslie. That was wonderful. So let's open it up for discussion. Any questions from the audience? Any comments? And I want to applaud everyone who's still here. I mean, it is a Friday night, and it is late.
The bar is still open.
And the bar will remain open.
Got one?
Yeah, go ahead, bud.
Josh?
As it was just said, cervical cancer.
Mike, can you use Mike?
Yeah, just a comment as it was said, truly appreciate everything you're doing. We love opening the trials. I think we all feel that cervical cancer probably right now is the area that we just don't have a lot of trials in the pipeline for us to open. And so just keeping that in mind is an unmet need for us to get those patients on trials. I mean, there are a couple trials out there, but really hoping for some more options for these patients. So thank you.
Yeah, many of you are phase 1, PIs. As you work through phase 1, you've got cervical cohorts and they look good. And you've got a company, the challenge is that a lot of these drugs are in China. And I don't know if you've read the news lately, but that's not exactly going to be easy to get them here to the U.S. And so it's really important that we all work as a group to bring these trials to later
that's
phase.
it's a really strong point because we really do need U.S.-like patients to evaluate this, and the FDA is requiring it. That we have to have a significant proportion of them so we can evaluate the efficacy and safety of these assets. We really need to support the trials that we can open in cervix. Yes, ma'am.
Hi there. You have 2 patient advocates in your audience.
Yay!
Sorry, and thank you, because from the ovarian perspective and the uterine perspective, we want you to know how valuable your work and this presentation is to us, and that we know that we have all of you in our back supporting us.
Thank you for being here.
Thank you for being here.
You're going to make us cry.
That's a tough one to follow, but anyway.
We're gonna bring you to more of our talks. This is great.
Any final questions, queries, comments from the audience?
Pretty robust.
All right. I'm sure everyone would like to go get a drink or at least go to their room and relax or whatever. Go get dinner.
I do what you did to me. So let's wrap it up.
That's it?
Let's wrap it up.
That's what we're doing, Dave, if you shut up.
I know.
All right. So this concludes our presentation and discussion for tonight's 10th highlight reel. 10th highlight reel. I want to thank all our panelists except Dr. O'Malley. No. I love my Irish brother. Come on. No, I want to thank everybody. It was a great job. Everyone did a great job presenting, stayed on time. It was really good. The audience engagement was wonderful. So thank you for that. I want to also thank our supporters. Where are our supporters here? Here we go. Thank our supporters tonight: AbbVie, Acrivon, AstraZeneca, Corcept, Eisai, Eli Lilly, Gilead, GSK, Karyopharm, Merck, Pfizer, and Veristem. As a reminder, to earn your CME credits, please complete your online evaluation, which will be sent to you via email. Earn up to 2.5 credits. And a recording from tonight's session will be available at our website. It's on this slide here as a podcast and on YouTube. Please follow us on social media to find out when this is available. We're on X, Facebook, LinkedIn, and Instagram. Plan to see us again in January at the Energy Semi-Annual Meeting, January 28th through 30th in Las Vegas. What could go wrong there? Anything? No? All right. Highlight reel will again be presented on Friday, January the 29th. So spend another Friday night with us in Vegas. We'll see how that goes. All right. Thank you. We're going to keep the bar open for a bit to allow some networking. And thank you all for being here tonight. Enjoy your rest of your meeting. Thank you.